So I see over 50 participants. I'm sure more people will be joining here in the next few minutes, but to try and keep with our scheduled program, we're going to head and get started. I'm Scott Tykody. I'm sure many signing in know me, but I hope there's some people outside of our care network that might also be joining this morning. Next slide, please. I'm an associate professor here at Fred Hutch and the University of Washington, and a clinical provider and clinical researcher. And my specialty is kidney cancer. So I'm very, very excited to be here this morning. This is our 8th annual program for our kidney cancer patients and caregivers. We started in 2015. We had a 1-year hiatus because of COVID, but have enjoyed making this an annual event. And I'm joined this morning by my co-host, Dr. John Gore, who, again, many of you in the audience know Dr. Gore as your surgeon. He's the Jesse H. Bridges Endowed Professor in Prostate Cancer Research in the Department of Urology at the University of Washington, and a member of the Fred Hutch Cancer Center as well. And we'll be taking you through the program this morning. Next slide, please. This is just an overview of the agenda that we'll be working through, and I just wanted to point out we will take a short break mid-morning and then come back and finish out the program. Our target is to be done at approximately 1 this afternoon. Next slide. So just a couple of housekeeping items, and then I'll hand over the program to Dr. Gore. The event will be recorded. We will curate and ultimately post talks on the Fred Hutch website. So for anyone who's not available today or wants to go back and review the talks, they will become available, and registrants will be notified when they're posted. People participating are not able to ask questions verbally, so please use your chat function. We can see questions entered into the chat, and we'll try and address as many questions to the individual speakers at the end of each talk. Some of our speakers are not able to stay online for the entire program. So don't be bashful and submit questions you have for individual speakers, and we'll try and address those in real time as we go through the individual talks. The Zoom link remains live. If you intentionally or accidentally leave the program, you can just follow the link and come right back in. So you're welcome to leave and rejoin as many times as you'd like. And then we encourage folks to send us feedback. There's a feedback form that you'll see the link in the chat. We'll also broadcast that through the email links that we use to notify people of the program. We do review the information you send us at the end of each year and try and take future programs to be responsive to comments that we receive, topics that people would like to see in future programs. And we love to receive comments regarding the virtual versus in-person format. As COVID has receded a bit, we've debated the benefits of going back to an in-person or a hybrid or remaining virtual. One of the benefits of the program is certainly time savings for participants, and also our ability to recruit participation from people that aren't in the Seattle area. And I think this year's program certainly reflects our ability to have folks join us from a lot of different places. So we'd love to hear the perspective of the audience going forward, and we'll certainly take that into account for future programs. So let me turn over the program to Dr. Gore to welcome you and then lead us through our morning slate of speakers, and then targeting a break about 10:30 this morning. John?
Thank you so much, Dr. Tykody. I really appreciate seeing that number under the participants tab. Keep clicking up, and I see a lot of names that I recognize. The feedback that we get from you all is really critical to how we design this event and who we invite for speakers and what content areas that we really want to focus on. And we really try to have an event that's engaging. So I appreciate all of your attention today. We're really delighted to have a speaker today that I think are going to give a really wonderful overview of a lot of the core areas of kidney cancer that are relevant to the kidney cancer patients of 2023. And so it's my pleasure to introduce our speakers for the morning slate of talks. And then, as Dr. Tykody mentioned, we will have a short break. Feel free to come out of the meeting as you see fit. I'm really delighted to introduce our first speaker, Brian Lewis, who is the president and co-founder of KidneyCan, and has spoken at this meeting before. You may recognize Brian from other events, but I'm really honored and delighted to present Brian, who's going to talk to us about his advocacy work on behalf of kidney cancer patients.
Thank you, Dr. Gore, and thank you, Dr. Tykody, and thank you, Rita, for the opportunity to speak. It's always an honor to get to speak to folks out on the West Coast, and look forward to talking for a few minutes here. I'm going to probably go really fast on my slides, and I thank Rita in advance for advancing the slides for me. So we're going to hit the ground running. As Dr. Gore said, I'm one of the founders of KidneyCan. We're a little bit different advocacy organization that we'll talk about here in a minute. I'm a husband and a father. I was an incidental finding in 2007, and the doctor on the right, Dr. Brodslavsky, at the NIH, and he's now leading urology up at State University of New York. And that's my family. Those two twins are now 17. They were about 1.5 when I was first diagnosed. So exactly, So my disclosures, we receive funding for kidney cancer activities and research and advocacy from these organizations, but also hundreds of patients and caregivers around the country. I serve on the NCC and guidelines panel, and I'm also at the KCRP's external advisory board, also working with the IKCC and lobbies. Next slide, please. So the mission of KidneyCan, which envelops everything that we do and touches everything that we do, is accelerating. We're not accelerating cures in the work that we're doing. We should be doing. What came out is we realized that some of my colleagues on the call today are going to explain to you a lot of the patient support services that are already in place. KidneyCan didn't want to go down that path of recreating the wheel, and so we compiled a list, and I'll share you and a lot of resources that's already out there in our patient resources. But our focus has always been advocacy, and primarily advocacy in Washington, D.C. So we'll get to that sort of towards the end. But I'm going to catch up here and go on to the next slide. So back in 2015, I met Ralph and Brendan Apps were funding the first privately funded clinical trial back called the RADVAX trial out of Texas. And over years, Ralph and Brendan and we worked together, and I was doing the advocacy work in DC, and they were doing sort of the grassroots efforts for fundraising. And we got together, we decided, let's expand, we reached out to some other patients in the community and formed KidneyCan. Next slide. So we created I'll highlight these real fast. This is our patient resource center. Folks have a lot of resources developed. If you look at our website, we compile a lot of different resources globally. A lot of questions focused around what the patient our website or the caregiver website. What do you need first? And we talk about developing a care team, et cetera, and looking for clinical trials and other things. Take a chance and take a moment if you can. That's this awareness and advocacy. You can see up in the right-hand corner of our slides. We try to tie in the color codes to our mission. Also, if you want to just keep on to the next slide. We also do these town hall events across the year. We try to bring together experts and patients and have free webinars that talk about different sort of theme topics going across the year. All these are recorded. You can see those on our website as well. Next slide, please. We have a partnership with the National Kidney Foundation, which is live patient webinars. We've been doing this for years now. Again, the National Kidney Foundation has such a huge footprint, and there is some correlation between kidney disease and kidney cancer. So we partner to try to bring some of these kidney cancer issues of awareness to the kidney disease community. Next slide, please. The one group I want to really emphasize, everybody who's listening here, if you haven't had an opportunity to get to know Smart Patients, I strongly recommend that you do. It's a closed community of folks in the kidney cancer ecosystem that talk to one another and share information, but it's not done, it's monitored. And there are a lot of experts on there, or folks that have been around for a while dealing with a lot of these issues. You can get a lot of questions answered that you might not have had an opportunity to discuss with your nurse or physician, but you can always refer back, of course, to them for follow-up. Next slide, please. And so what we can is, how does kidney cancer research really happen? Well, we all know it takes people. It takes a lot of people. And so next slide. But it also takes a lot of money. It takes a lot of time. You can see the FDA new drug approval process many times, anywhere from an average of maybe 5 or 6 years up to 10 years from the initial clinical or basic research that's done all the way through a phase 3 trial and the opportunity for patients to utilize the drug. Next slide, please. So what we thought early on when we were starting up KidneyCan is the kidney cancer as a disease group is terribly underfunded. You can see here based on the American Cancer Society state data back in up through 2018, we only had 13 grants for kidney cancer from the American Cancer Society. You can see a lot of the other are way ahead of us. Next slide, please. So we created what are called advocacy days in Washington. We would bring people together, we would train them, and continue to do that. We'll talk about that in a moment. But through COVID, we switched to the virtual environment, and we're doing numbers of Zoom calls, which were just as effective sometimes as in person. But now we've come back to a hybrid program. And so we've done, I think, close to over 1,000 meetings on Capitol Hill. We've had over 800 advocates come with us to DC, and we'd like to recruit some more. Got in your part of the world because your senator in Washington now is at the top of the appropriations committee, and we would love to have folks from the Washington area involved with us. Next slide, please. So our participants, and you're building out 50 million. Maybe we could push that number up again going forward. So what does all this mean? We got money for kidney cancer research, to help them grant. So what? Well, next slide. What we decided to do is we pulled the early from the dedicated funding, and we found out that the researchers weren't talking to one another, and it wasn't intentional. Doctors and researchers are very busy people. They get in their laboratories. They're trying to solve problems. They don't always have time to go out and share their research findings. So KidneyCan, with some partners and some private funders, we decided to bring all those folks together. We created the Kidney Cancer Research Summit, and we're now on our 5th year. Next slide, please. We just bring researchers and the grant recipients that have gotten this funding through the DoD to come together and share with their colleagues what they're doing and how the research process is hopefully going forward and impacting patients. Next slide, please. This is just a continuation of, I think, photos of that slide. So we keep going here. So we're making progress. We've gotten to $235 million, and we continue to do that. The difficult part is that every year Congress has to appropriate a new set of funds for kidney cancer. It's not an automatic rollover, and so we have to continue to go back to Washington and ask and basically say, we need this money. This is what we've done with it. The community has done with it so far. Here's what we need more for. So we can use your help there. We've also created this grassroots army. As I mentioned, we've had a clinical trial, and we've just completed our 5th Kidney Cancer Research Summit. However, there's a lot of work to do. You can see the numbers out there. We continue to have increase in diagnosis every year. The number of deaths from kidney cancer in the United States continues to climb. So we have a lot of unmet needs and some funding gaps. Next slide. Our next activity is we have one group dedicated to folks coming to Washington from its target hours regarding the purchasing of food meeting. And it's never negative related to so as mentioned, necessary full right support all the information we'd love to have your report. Next slide, please. And I will finally hand back over to Dr. Ward. So take it to the next slide.
And some plan wonderful, really important and have seen the last 7 years dedicated funding towards this everything here credit destinations for all you guys. Thanks for the overview of what's going on nationally. They also have other graphics here. We'll introduce Julie and Art tomorrow. We've been based out of the Hutch for as long as I have been here, and this is my 50th year here at the Hutch and UW. So Julie and Art, thank you so much for being here.
Hi there. You'll have to forgive me. I have a sinus infection, so I'm a little froggy. But anyway, sorry. I'm Julie Shimura. This is my husband back here somewhere. Wanted to give a little background as to my kidney cancer. I'm a 23-year survivor. Yay. I had 3 surgeries because I had tumors in both kidneys, but I've never had any treatment at all. Apparently the surgeries took care of that. I also, 23 years ago, there was hardly anything on kidney cancer. So my husband and I did a lot of research and couldn't find anything, but there was something in Chicago. So we took a trip and went to a convention they had there. Here we go. And we got a lot from it. We met a lot of people, but we wanted to know more. So we came back and talked to John Thompson, Dr. John Thompson at Seattle Cancer Care Alliance, who is awesome, really helped us a lot. And he's helped us set up our first meeting when we had 30 people at the meeting room. We also had, as we went around to all these conferences, we gathered that information and we presented it to our people here. It really was helpful for the people to get this information because they had no other sources. Of course, now there's, the internet and you can just look up anything, but having that personal interaction was very, very helpful. And it is to this day. Just ask these people that are on here. Let's see, what else do I have?
Kidney Cancer Association.
The Kidney Cancer Association, at that time, that's what it was called. They came out and did a couple of
Meet and greets.
Speaking to our group, and we learned a lot more about treatments. Treatments were at that time IL-2, interferon alpha, I think, and that was about the size of it. And of course, now we have multiple treatments, which are awesome, wonderful, and hopefully they work for people. Let's see. We went, let's see, where are we here? Help me out here, bud.
Well, we went to multiple sites. We went to Houston, we went to Washington, DC, we lobbied twice at Congress. We've been down to Los Angeles, San Francisco, many times in Chicago. All of this was stuff that we could bring back to our local group until March 20th of 2020, when COVID knocked us out of the agenda at SCCA. We didn't have a meeting room. And we haven't met since, but there have been online, Julie gets emails and talks to people. She gets referrals all the time, but we have not met personally since COVID.
Yeah. I hope to keep going, but I'm getting a little old in the tooth for this. I can't travel anymore, but we still want to do something for the kidney cancer people and the doctors and so on. But that'll come. I guess that's about all I have to say, because right now I'm not feeling that great.
Well, butting in on Julie's talk, when she was diagnosed, December 7th, 2000, she went on from there to her multiple surgeries in 2001 and 2003 for kidney cancer, but she's had other surgeries, abdominal surgeries as well, which is one of the things that we always have to be aware of: side effects. Surgery side effects, bowel blockages, hospitalized 7 times for that. There are also side effects from all of the new treatments that are out there, which I'm sure many of you that are patients know all about. But back in 2004, when we started our meetings, they were talking about 32,000 new patients identified per year and 13,000 deaths, which is a horrible statistic. And from what we just heard from Kidney Can, it's now 82,000 and 15,000, which is a tremendous update. I think a lot of that is due to the greater prevalence of having scans that are identifying the kidney cancer, but there's also a lot of that is due to all of the treatments that have been developed. The very first one that gave us any real hope was sorafenib, and then came sunitinib, and it just kept going from there. Back when we had our first meeting in 2004, Dr. Thompson told us to all feel good because there's a lot of stuff coming down the pipeline and things are going to get better very soon. And he was right. So we've shared that for, well, at least 20 years until we got knocked out by COVID. And we are just real happy to see that this is going on and continuing, and that we hope everybody, I had to put in a plug, caregivers. I'm a caregiver, and there's a lot of caregivers on this call. I want to point out to you that caregivers are involved in this up to their necks too. And one of the prime examples of that, one of the meetings Kidney Cancer Association held in Chicago, they had 2 breakout sessions, one for the patients, one for the caregivers. Caregivers, by and large, are stiff upper lip, keep a straight face, smile, stay quiet at all of these conventions. Went to the breakout session and things changed. People in the breakout session talked about their fears. One said, my husband's a dentist. What happens if he dies? We've got small children. And she broke down, something they don't do in the sessions. So remember the caregivers and take care of them as well. You caregivers are important. And I guess that's my story.
Thank you both. Clearly, there's a gap right now in our local support advocacy, and so it's something we should definitely chat about. But thank you for sharing your story. And I can't echo enough, mindfulness about the carers. One thing we always forget about as care providers is who cares for the caregivers. So thank you very much, Art. I'm delighted to present our next speaker, who I've been working with for many years, and who has initiated a really innovative clinic at the Fred Hutchinson Cancer Center that is a transplant immune oncology clinic, given that so many of the cancers that we care for these days are managed with immunotherapy, but among transplant patients who need to have immunosuppression, it's a really challenging decision-making milieu. So I'm delighted to present Dr. Christopher Blosser, who's a physician both at the Hutch and at the University of Washington. Dr. Blosser is a clinical professor of nephrology and director of the Cancer and Organ Transplant Clinic at the Fred Hutchinson Cancer Center. And Dr. Blosser is going to talk about the role of our immune system in kidney cancer.
Thank you, John. It's great to be with all of you this morning. Thanks so much for the invitation. What I hope to do is to offer just a general review that hopefully is accessible to all of you in ways that allow us to think about how the immune system plays a significant role in kidney cancer. And I take a slightly different view than Dr. Takoti and Dr. Gore in that I care for people who need and receive organ transplants, mostly kidney transplants, and sometimes they need kidney transplants because they've had kidney cancer. All of that leads to a different balance of keeping the immune system healthy, trying to prevent rejection of the organ transplant while also preventing kidney cancer. So this is a picture that I took off the web, but it reflects the idea that the immune system, and in this case the T cells, are so important in being able to attack a cancer like kidney cancer. And so the T cells are the pink cells here that are going after the cancer here in the middle. And that's critical for much of what we try to do in the control of cancer nowadays. I do have funding from the CUNY Foundation and an editorial board member for the American Journal of Transplantation, but that's my only disclosure for now. I hope to briefly talk with you about the immune system and how we can use treatments to activate the immune system, hopefully safely, and talk about the cancer and organ transplant clinic in the setting of organ transplantation. We all know that the US and world population is aging, and as that happens, more people are living with chronic conditions. All those chronic conditions, unfortunately, can lead to more organ failure across the general population. And with organ failure, there's an increased risk of cancer, and that includes those who have chronic kidney disease, heart failure, liver disease, all of that increases. And so naturally, more people are coming into the need for an organ transplant with a history of cancer or a risk of cancer. We know people who have chronic kidney disease, end-stage kidney disease on dialysis, or those who have a transplant are at least 1.5, all the way towards 4 times higher risk of cancers compared with the general population. And kidney cancer is a top 4 cancer in those groups of people. As you can see on the right side of this figure, the most common cancers are skin cancers, and another common cancer is lymphoma. But kidney cancer continues to be a significant risk for people, both before an organ transplant, especially those with kidney disease, and those after transplant. And we've done so well at keeping people alive longer, even with their chronic conditions, that we've been able to better control cardiovascular disease and the death from that. We've been able to improve outcomes from infections. And out of that has led more time for someone to live. And with that time and the related risks, people are unfortunately dying more from cancer than before. And you'll see that that's especially the case in the setting of people on dialysis who are 12.5 times higher risk of dying from cancer, and kidney transplant recipients who are almost 8 times higher risk than the general population. And so I guess I frame that to say we are facing challenges, and yet I think we're ready to do that. We're ready to face those challenges together with greater knowledge and new therapies that we didn't have before. As you've been talking about for the last minutes, we're seeing an increase in the number of people across the world who are dealing with kidney cancer. Most of those cancers are thankfully localized within the kidney and can be addressed with surgery, but not all of them. And that's where more of the complexity of caring for people who have chronic conditions or an organ transplant with kidney cancer becomes a challenge that we need to face. Some of those risks for kidney cancer that we've been trying to, with you, bring to light and address include smoking, higher weight, high blood pressure, more males than females develop kidney cancer, and advanced chronic kidney disease is another risk factor. I name those along with immunosuppression as 5 of the most common risk factors that I face in the patients I care for. Why is that important? Well, when we think about chronic disease or immunosuppression after an organ transplant, all of those components lead to a greater risk of kidney cancer. And why is that? The immune system is so important in everyday work to keep us well. The immune system looks around our body looking for cancer 24/7. And normally, if the immune cells see a kidney cancer or some other kind of cell that is a cancer cell, it can identify it as cancer and then kill it. Unfortunately, when we are living with a chronic disease or immunosuppression after an organ transplant, those normal functions are blunted so that parts of the immune system that identify abnormal cancer proteins aren't as numerous or as functional, and so that surveillance is not as good. The T cells that are major drivers, like generals in the army, giving signals to the rest of the immune system, are not as active, are not as numerous. And so then the attack against the cancer, once it's identified, is less strong. And finally, there are certain parts of the immune system that are intended to blunt an immune response so that we aren't too inflamed. And oftentimes those regulatory cells are higher in number in the midst of immunosuppression. All of this leading to a cancer and the cancer's ability to grow more easily. So when we think about therapies that may be used for kidney cancer, as was named just a little bit ago, some of the therapies that have really been useful in the recent past and continue to be now are the VEGF tyrosine kinase inhibitors. And those are antibodies that have been created in the laboratory to change signals in the body and alter blood flow, development of new blood vessels, and decrease cell or cancer development. Unfortunately, there are side effects with those, including for people that I care for, they have a higher blood pressure, more protein loss in the urine, which is not a good thing, potential blood clots or cardiac toxicity, sometimes bleeding or intestinal perforation. All of those are things that we need to consider when using the tyrosine kinase inhibitors. As an alternative therapy, especially in the general population, there are new immunotherapies that can be used to activate the immune system to wake up, especially the T cells, parts of the immune system that are main activators and guides of other immune system reaction against cancer. And the PD-1 and PD-L1 immune checkpoint inhibitors have been very effective in being able to activate a response against kidney cancer. CTLA-4 immune checkpoint inhibitors have also been used historically, and that is something that can be used in combination with a PD-1 inhibitor. Both of those are intended to wake up the immune system and really lead to a strong anti-tumor effect. As was mentioned in the historic past, IL-2 and interferon alpha have historically been used, but not as much now because of the significant side effects. As you know, every medicine has side effects, and immune checkpoint inhibitors have multiple potential toxicities. That's because the signal to wake up these T cells and do the work is not precise at the place of the tumor. And so any part of the body could potentially also have experienced toxicity from the immune system being active in that space. And we can see that across the GI tract, which is common, the skin, or other parts of the body as well, as listed here. The problem when we consider using checkpoint inhibitors in the setting of organ transplant is that those checkpoint inhibitors are intended to wake up the T cells, the same cells that we are trying to suppress with an organ transplant immunosuppression to prevent rejection. The T cells really are good at rejecting or identifying anything, including an organ transplant. And so we have to use medicine every single day for the patient who has a kidney transplant to prevent the rejection of that kidney transplant. So if we add a checkpoint inhibitor in that situation, there's a much greater risk of kidney transplant rejection. Just last year, Dr. Takoti and others at the Hutch worked with me and we identified what is the risk of rejection for people treated with checkpoint inhibitors for their cancer in the setting of organ transplant. And what we found was that at least 35% of those patients, up to 50% of them, would develop rejection within 2 months of starting checkpoint inhibitor therapy. It's a great example of how this immune therapy is really effective in waking up the immune system to do its job to attack the cancer. And yet the risk is that the person could lose their organ transplant, especially if it's a heart or a liver or a lung transplant where there is no other backup like dialysis. That is an alternative serious risk of death. And so we need to think about how we can balance those risks. And we've come to learn more about how to do that while using these immunotherapies as effectively as we can. That can include a lower dose or less frequent infusions as considered the standard. And we're starting to see potential benefits with that. Naturally, that balance, that treatment of cancer while maintaining the transplant leads to difficult choices. So I wanted to offer an example of a patient who I had the chance to care for the last few years. When he came to my clinic with these symptoms, he was 83 with hypertension, atrial fibrillation, which is an arrhythmia of the heart, Addison's disease, meaning his adrenal glands were not making as much steroid as normal, and chronic kidney disease. He was identified to have a kidney cancer in 2010, and at that point there was no evidence of local invasion, and so the kidney was removed. And for other reasons, he waited 6 years before receiving a kidney transplant. That was in 2016. About 3 years later, unfortunately, he came back with neck and back pain, and we found that he had metastatic kidney cancer along his spine, along with some bones in his face. And so he underwent resection where appropriate and fusion of some of his spine vertebra, some radiation to the places where he had additional metastases. And then he asked the appropriate question, especially because he was a former physician. What are the best therapies that I possibly could get right now to maintain a good life with advanced kidney cancer? And he asked, could I be treated with a checkpoint inhibitor? And this was not long after Jim Allison and Tezuko Hanjo had won the Nobel Prize for their fundamental work leading to the medicines that we now use, the immune checkpoint inhibitors. And this was just about a year after they were awarded the Nobel Prize. He asked questions like, can we use immunotherapy? Will this potentially impair his kidney function and his general health? Will the treatment potentially improve his survival? What kind of surveillance is best to see whether or not he's having rejection and how he's responding to the treatment? All of this reflected, what did he want? He wanted a better quality of life where he could go fly fishing, hiking, travel with his family if possible. And out of that, and some other examples of working with people like him, I wanted to create a better way to care for people. And so in 2020, I was able to establish the Center for Innovations in Cancer and Transplant, which is intended to transform lives through the clinic and research of people who have cancer before and after organ transplants. The clinic is the first of its kind that we know of that is multidisciplinary consult clinic for people who have cancer either before or after an organ transplant. And the questions that we want to help answer are when a person can proceed to receive an organ transplant after they've had cancer. What are the optimal therapies to help them get there? And if they have cancer, like the patient I just mentioned, after a transplant, what are the best treatments to help them thrive? This is a partnership between the Fred Hutch and UW. We see people at least twice a month, and it typically is 3 new patients in a clinic. We can see return visits as well. And in the first hour, 1 patient will be seen by an oncologist, while another by a transplant doctor, and where appropriate, a surgeon such as Dr. Gore. And in the second hour, we switch places so that each patient is seen by each relevant doctor, cancer and transplant. And in the third hour, all of the providers come together to discuss each patient they've seen, to coalesce a consensus agreement and recommendation for care going forward. And then we go back to each patient and provide them with our recommendations in person together. And we record those recommendations with a dictaphone basically, and give them the audio recording of that conversation on a zip drive that they can take home and listen to again in case they don't remember all the conversation points, knowing that it can be a lot. We're definitely available to answer further questions that the patient has, and we also then communicate with the referring providers to ensure that that care plan works with the plan that they had seen and can support the ongoing care of that patient wherever they are. These are some of the team members in the Cancer and Organ Transplant Clinic, representing almost every cancer type that is seen at the Hutch, and you'll recognize some faces here as well. It's been a great pleasure and honor to really work with all of these folks and provide care in these unique and challenging situations for patients who naturally feel like maybe they don't have as many options and we want to really optimize every situation possible. I come to this with the belief that it's really important that we take consideration of the patient's health and life goals to personalize their care. Yes, we need to consider the cancer and the biomarkers that we can use to follow them in the care. We need to continue to use the currently available treatments where appropriate, considering those off-target effects. And like the case I mentioned, the risk of rejection is a real example of that. And as we kind of think forward, we've come to better refine how to also use immunosuppression, meaning how much immunosuppression, what medications to use to prevent rejection, while also using the best therapies for the cancer. And so this is an example of how, depending on the type of cancer, we may diminish or stop the immunosuppression altogether, depending on the patient's condition. When using checkpoint inhibitors, I often will decrease, but not entirely stop immunosuppression, because we know that if we stop the immunosuppression, there's a much greater risk of rejection. In the case of the patient who I told you about earlier, when we identified his cancer and he wanted to start checkpoint inhibitor therapy, we actually did that in addition to axitinib, a VEGF inhibitor, and that was in October of 2019. I switched him from one type of immunosuppression to another to optimize his anti-cancer effect while preventing rejection, while continuing low doses of some other immunosuppression. And you'll notice that he was able to continue with the checkpoint inhibitor therapy for basically 3 years. He experienced no signs of rejection. And finally, in late summer of 2022, he passed away from his cancer after having had the experience, in his words, of a much better life than he could have anticipated, including being able to travel with his family to Hawaii, to go fly fishing and hiking like he wanted. And he and his wife thanked me and thanked our team for the opportunity to optimize the life that he could live, understanding that every single day was important to him, just like us. So as we thought through how to prepare for the end of his life, elements that are probably obvious, but I'll just name, include that patients who have cancer in the setting of transplant or kidney disease have more symptoms, more pain, have altered metabolism of the medications that they take, so that things are more complicated and need more oversight. Oftentimes, if we can involve palliative care to help control pain and optimize quality of life, that seems to work better for people. And in this case, my patient did not want to continue life on dialysis if his transplant had failed, but others are of a different mind, and we want to help prepare for a transition to dialysis before it's emergent if their transplant fails. So all of those are components that we consider in the clinic and in ongoing care for people. While we do that, we want to continue to learn in order to help the future. And so our research part of the center investigates how people experience care with cancer. We also follow data and want to see how those trends inform and allow us to identify risks and treatments for cancer. And finally, we also do bench research looking at the immune system in people who have had kidney cancer before and after transplant. And that's enabled partly through the registry that we have here. So we have a registry of patients who have cancer before and after organ transplant, and we partner with other cancer centers and transplant programs around the country to really enlarge the number of patients who can contribute to this learning that we do for the future in order to really hopefully help the long run. Our organizational structure is unique in that we have a scientific advisory committee and a community engagement committee made up of patients and other experts to guide us on the decisions that we make, the grants that we submit, the papers we write, in order to hopefully help answer directly important questions for patients. With the bioregistry, we've been focused on studying immune checkpoint inhibitors in the setting of transplant, along with CAR T cells, which is another way to use the immune system against cancer, and studying certain types of immune system properties, and specifically in kidney cancer, so that we can better understand and move that forward. By pulling these threads together, we know that we can learn more together than if we were to do it alone. And so these are members of our research team that I'm really happy and proud to work with. And honestly, I couldn't even fit all the pictures that I wanted to on the slide. So I just want to say thanks to everybody who's a participant on multiple levels. Finally, we know that the immune system is central to controlling and reacting against kidney cancer. Those with organ transplants are 2 to 4 times higher risk for cancer, including kidney cancer. And so using immunotherapies can be very effective against cancer, unfortunately, with the higher risk of rejection. And so we need to balance those together. Working together, partnering with oncology, palliative care where appropriate, is really valuable in order for us to get the best outcomes every time. So I think at this point, I'm going to stop and thank the patients, their caregivers, transplant and Fred Hutch teams, the research team I get to work with, along with the Kidney Research Institute, who I'm a member at, and welcome your comments and questions. Thank you.
Thank you so much, Dr. Blosser. That was a really wonderful overview. I felt like I learned a lot, so thank you very much. We do have one question in the chat, which is, are there any foods that can strengthen the immune system?
That's a great fundamental question. And from my perspective, I would say a healthy, balanced diet that fits with any other guidance that you've gotten from your providers is most important. Certain foods, fruits and veggies definitely have the potential to help our immune system be healthier than a lot of protein, especially meat-based protein. So oftentimes a fruit and veggie based diet is probably more valuable than we give it credit for.
And then a question from our own Dr. Taikoti, and this is an arena where you and I often have to have a conversation, but if you have kidney cancer and develop end-stage renal disease, how do you make decisions about wait time for eligibility for a kidney transplant?
Yeah, thanks for asking that, Scott. The decision around waiting for a kidney transplant considers the risk that the kidney cancer could come back when adding immunosuppression. And so we look at a number of factors, and the more we learn, the more precise we hopefully can be at predicting that, including the stage of the cancer, the treatment that the person receives, and then following for any signs of recurrence through imaging or, where appropriate, blood testing. Oftentimes, it's relatively predictable, and we now have some guidance in terms of the number of years. It's at least, for someone who has localized cancer, 1 year of waiting. For those who have metastatic cancer, we have to be careful that it really could still be hiding somewhere. But in between stages 1 and 4, there are opportunities for people to receive a transplant with time that they've been able to stay healthy. Naturally, we need to consider all of their health and ensure that we would be helping and not hurting someone with a kidney transplant and the associated treatments.
Thank you very much. I think a lot of the other questions just relate to just being grateful for your talk. So thank you so much for your time and for joining us today. I didn't mention that Dr. Blosser is on service, so he's doing this while trying to navigate busy clinical. Sorry for that interruption. So we're going to turn the morning over to someone who's also an integral part of our kidney cancer team. Lauren Ficini works in our multidisciplinary kidney cancer clinic to help us make decisions about genetic testing, patients we think are at risk for syndromic kidney cancers, and she's going to talk to us about genetic testing for hereditary kidney cancer. Thank you so much, Lauren.
Yeah, thank you. Let me go ahead and share my screen here. All right, let's get this up to the presentation view. All right, I hope that looks okay for everyone. So again, my name is Lauren. I'm a genetic counselor here at Fred Hutch, and I have kind of a little niche specialty in hereditary kidney cancer, but I do focus in other types of GU cancers as well. Just for a brief overview today, so we're going to be talking a little bit about cancer genetics and genetic testing, what hereditary kidney cancer looks like, the pros and cons of doing genetic testing. We'll walk through an example case, and then we'll end on a note about direct consumer genetic testing, and hopefully I'll have some time at the end for questions as well. So we're going to be talking a lot about genes, so let's just take a step back here and kind of review the basics. So our body is made up of cells, and in each of your cells, you have your chromosomes, 23 pairs of them. Every single one of your chromosomes is made up of DNA. So if we think of DNA, it's really just one big instruction manual for your body. Genes are actually specific instructions. So they encode for proteins, and those proteins have specific jobs in the body. So when we're talking about genes, we're really just referring to a small piece of your DNA that has a specific job that encodes for a specific protein. Close that chat there. Okay. Oh. Sorry, my slides are stuck here. Give me 2 seconds. Here we go. Okay. So genetic mutations are really changes to that DNA within a particular gene. So again, if we think of DNA as being an instruction manual, mutations are really just misspellings within that instruction manual. So you can kind of see here in this little picture we have, sometimes that's a misspelling. So where there was a T, we now see a C. Sometimes it's actually missing or added pieces to the instruction manual or to the gene. And now sometimes these changes aren't actually harmful. We actually have lots of these different genetic changes or mutations. And for most of us, they aren't really causing any harm. But when these mutations are happening in a gene whose job it is to really protect you against cancer, so let's say they're a tumor suppressor gene or they help regulate cell division, that's when things can really go wrong, because if it's impacting the way that that certain gene works, then we can see that it's just not working properly. And if that gene's role is to protect you against cancer, you might have less protection against it overall. All right. So there's a saying I really like, and that saying is all cancer is genetic, but not all cancer is inherited. And what that really is referring to is the fact that there really are 2 types of genetic mutations. The first is what we call somatic genetic mutations. And really what we're saying there is, look, every type of tumor, every type of cancer actually has genetic mutations, but most of those are acquired. So they happen at some point in the person's life. They're really isolated just to the tumor or the cancer itself, so they're not present in other parts of the body, and they certainly can't be inherited or passed on. The second half of that statement, not all cancer is inherited, is really referring to the fact that there's also these germline mutations. Now, germline mutations are present in the sperm or the egg, and they are inherited most of the time. So they're typically present in every cell of your body. And these, again, can be risk factors for hereditary types of kidney cancer. And as a genetic counselor, this is really the type of genetic mutations I specialize in. And when we talk about genetic mutations moving forward, we're really going to be focusing on these germline or inherited types of genetic mutations. Okay, so how does genetic testing play a role in all this? Well, genetic tests help us identify mutations in your DNA or your genes. And just like there's 2 different types of genetic mutations, there's 2 different types of genetic mutation testing. So we can have tumor or somatic type of genetic tests. Those can help us determine the nature of the cancer, help guide treatment. That's when we actually test the cancer cells itself. So like from a biopsy or a prior surgery. We also have some technologies that allow us to test tumor cells from blood, which is pretty cool. And then there's also germline genetic testing, and that helps us determine if you were born with one of these germline genetic mutations that puts you at a high risk for cancer or cause these hereditary cancer syndromes. And again, this is the type of genetic testing that I really focus on, these germline inherited-based genetic tests. So what do we know about hereditary kidney cancer? Well, most cases of kidney cancer are sporadic. They happen by chance. They're caused by those somatic mutations we talked about earlier that just happen at some point during your lifetime. So there really isn't a hereditary cause to them. But what we've learned after studying so many patients with kidney cancer is that it's around 5 to 10% that are clearly hereditary or genetic. So I use the example of if we were to test every single patient at Fred Hutch who had kidney cancer, we'd expect that 5 to 10% of them to actually test positive on one of these germline genetic tests. They would actually have one of these underlying hereditary cancer syndromes that we think is responsible for their cancer and possibly other cancers in their family as well. So when I'm meeting with patients and we're talking about their own history of cancer and their family history, there's certain things I look for that make me a little bit more suspicious that the patients are going to fall into that 5 to 10% category. And those things in general are, first, young age diagnosis. So in general, I say, anything under the age of 50 is a little bit young for cancer. And certainly when we think about kidney cancer, when we're seeing it in the 30s and the 40s, we're starting to wonder, what's going on here? Is there a genetic predisposition for it? I also look if the person has had multiple cancers in their lifetime. So, maybe they're diagnosed with kidney cancer right now, but before this, did they have colon cancer? Did they have melanoma? Did they have pancreatic cancer? I usually say to my patients, getting a cancer at some point in your lifetime is actually pretty common, but getting multiple separate cancers that happen independently of one another is not. And then we can also see multiple family members, affected with either the same type of cancer or what we call related types of cancers. So again, when I'm looking at a family that might be, 3 or 4 people in one family with kidney cancer, where we're scratching our head going, this is more than just chance alone, or just again a whole bunch of what we call related cancers. So when I think of those certain genetic cancer syndromes, they can have risk for multiple cancers. So a classic combination might be melanoma with kidney cancer. And I'm saying, okay, we're seeing a lot of this combination in the family. Maybe that could be a sign of a certain condition. And then we also, look for cancers that have a high risk to be genetic. So an example of that is ovarian cancer or pheochromocytomas. Essentially, they have a higher than that 5 to 10% chance to be genetic. And then other clinical features suggestive of a particular condition. So some of these hereditary cancer syndromes, just cause cancer, but some of them also have other features such as uterine fibroids or certain skin-related features. So when I'm meeting with patients, I often ask about those things as well. And then pathology can play a huge role, especially with kidney cancer. So when I'm reviewing a patient case, that's often the first thing I look for in a kidney cancer patient. I'm saying, okay, what's the pathology? Is that going to give me any clues as to what they might be at risk for in addition to everything else? Okay, my screen keeps getting stuck here. Here we go. Okay, this is a little bit of a busy slide, but I just wanted to list out here kind of some of the more common hereditary kidney cancer conditions we think of. So one of them is von Hippel-Lindau disease. We can see clear cell renal cell carcinoma in that condition, as well as neuroendocrine tumors, hemangioblastomas, as well as a whole bunch of other signs and symptoms as well. Hereditary leiomyomatosis, renal cell carcinoma syndrome. That's a big long name. We call it HLRCC, caused by mutations in the FH gene. So we can particularly see FH deficient renal cell carcinoma. We used to call that papillary type 2 sometimes as well. We can also see uterine fibroids with that condition, certain skin-related findings as well. Bertog-Dubé is another condition caused by mutations in the FLCN gene. So in that condition, we can see chromophone or kind of this oncocytic hybrid renal cell carcinoma. Also, we can see a lot of lung cysts in that condition, which is unique to that. And sometimes those lung cysts can actually cause collapsed lungs. And then again, certain skin findings that look very different than the ones in HLRCC, but are pretty unique to it. And then there's also a whole bunch of other genes as well. So, BAP1, SDH genes, P10, all of those also have risk for kidney cancer, and impossible to go over them all, but those are some of the big ones. So when I'm meeting with patients and we're talking about, okay, their family history, their own history, is it concerning for a genetic predisposition, and we kind of lean towards yes, it is. Then we start the conversation of, okay, well, what are the benefits and the cons of doing genetic testing? What is this going to actually tell us, and how is this going to be helpful? So when we're thinking about genetic testing, I think some of the clear benefits are, one, it can really provide an explanation for the cancer history. I think a lot of patients are asking the question of, why did this happen to me? Or why do we see all of this kidney cancer in my family? And possibly this can provide an explanation to that. Or it can help rule out some of these conditions that they might be worried about. It can also inform the risk for additional cancers and symptoms. So, part of my job is to say, when the genetic testing comes back, okay, what is this gene? How high are those risks? And what do we need to be watching you for in the future after we get a handle on your kidney cancer? Do we need to send you to any specialty clinics? What are your risks for those things, and how are we going to manage you for those? With the idea of, if we know that these risks exist, then we can be proactive and hopefully either catch another cancer very early, or prevent it from happening altogether. And then, of course, it can provide risk information for family. And I think this is a huge motivating factor for a lot of patients as to why they do the genetic testing. They might say, look, for me, it's not going to change a whole lot right now, but I have kids, I have grandkids, I have nieces and nephews, and I'm starting to think about them and what their risks are. And if we can identify that genetic mutation in the person who has kidney cancer, well, then we can test the rest of the family for it. And we can say, do you have it or do you not? And if they do, we can watch them appropriately. And if they don't, well, then that can be quite relieving for them. And then again, potentially it may help guide treatment. This isn't as common in the kidney world, but we are starting to learn that for people who have certain genetic mutation, and this includes germline genetic mutations, there are certain treatments that might work better than others. And so it might not change what we do immediately, but it could help in that second or third line option, or it could open up doors for research. Some limitations of genetic testing, because like anything in medicine, there's pros and cons, and like anything, this is optional. People don't have to do it. I think some of the big limitations are, one, a negative result doesn't always fully eliminate your risk. So sometimes I have families who come in and there's 4 or 5, kidney cancers in the family, and we're saying, okay, clearly something is going on here, but we do the genetic testing and it comes back totally negative. In that scenario, I'm not going to tell the family, great, you're in the clear. Clearly something else is happening that we just can't detect. Our technology hasn't been able to find it yet. Maybe it's an unknown type of gene we just haven't discovered. And so, for some people, doing the genetic testing isn't always a perfect, satisfying answer. Also, more information isn't always useful. Sometimes I'm talking to patients who are kind of right in the beginning of their diagnosis. They're overwhelmed. They've got a lot going on. It's not going to immediately change, their treatment approach. And maybe they don't have kids and they're saying, look, I don't really need this information. I'm not really seeing how it can be helpful for me. So I don't want to do it now or possibly never. And that's very fair. As much as you have a right to know, you also have a right not to know. And then there's also the potential for uncertain results. So, again, this could be an uncertainty, like we found a genetic mutation in a gene we know really a little about. And I'm saying, look, we don't know a whole bunch about this. It may or may not be associated with your cancer. And we're going to have you check back in with us in a couple years just for updates and essentially until we know more. Or we can actually get what's called a variant of uncertain significance, which is a change in a gene, but we're not sure if it's actually harming the gene and causing the risks or not. And so again, sometimes it's not straightforward. Sometimes I'm having a conversation with the patient and there's a lot of follow-up, or there's a lot of check-in with us in a year, and that can certainly cause anxiety and be stressful for patients on top of everything else. And then a lot of times patients bring up genetic discrimination risks. I think, in general, you're more protected than most people think. My type of genetic testing is very different than like 23andMe or Ancestry.com, in that we're not connecting you with relatives or, your third-degree cousins in Germany. Really, this is private. It's kept in your medical record, and we're only looking at cancer risks. So we're not looking beyond that at anything else, and it's not being shared or used for any other purpose. But I will say there's protections, for health insurance, as well as employment. Those folks can't use your genetic test results against you. But there's loopholes for things like life insurance, long-term care insurance, disability insurance. Those types of insurances can use health information against you. And for most of our folks who have cancer, that's not a big concern at this point in time. But if I'm seeing like the child of someone who had cancer and they're young and they're healthy, that's certainly something we're talking about a little bit more in depth with them, just to make sure that they have those policies in place if they want them. Okay, let's do an example case. And this was changed a little bit more. You can see here on the right side of the screen, I have what's called a pedigree or a family tree. This is what we draw out when we meet with each of our patients. My patient here is this circle, which are females. So it's a 51-year-old female who came in and saw me. She had a history of kidney cancer, renal cell carcinoma at 46. And then she was recently diagnosed with colon cancer a couple years ago. And so that really is what prompted her to be referred to us, is the fact that she's had 2 cancers under 50. During her consultation, we filled out this family tree. I asked her about skin findings and she told me, we were on Zoom, so we couldn't really talk very well, but she said, I've always had kind of what I would call sandpaper skin around her neck and her face area. And we again asked about the family history and she told me, well, my mom died of kidney cancer too, but she was older than me. She was 60 when she had it. And then I asked about lung findings and she said, it's the strangest thing. My niece, who's 28, just had a collapsed lung. She had to go to the hospital for that. And I started going, this is interesting. So again, I would say that the things that jumped out to me is her own history of 2 cancers at a young age. The fact that her mom also had kidney cancer, and it's pretty unusual to see 2 cases of kidney cancer close together in a family. And then of course, her niece who had that collapsed lung, that pneumothorax. And her results came back as though she had a mutation in the gene FLCN, a germline mutation in that, which causes a condition called Birt-Hogg-Tuve syndrome, which really fit with her family history and her own history. We know with that specific condition, there's an increased risk for kidney cancer. There's also an increased risk for colon cancer, so it might possibly explain both of her diagnoses. And then patients also typically have these skin findings where it's almost little bumps across their face, down their neck, in their chest area. And she had those signs and symptoms. And then of course we can see this increased risk for lung cysts. And those lung cysts, if they get too heavy, they can kind of collapse the lung. And that's exactly what happened to her niece down there. So we're pretty suspicious her niece has it. She was going to go get testing. That would also mean her brother also carries it. And so the next steps for her were we referred her over to a medical geneticist. So that's a doctor who follows patients with these genetic conditions long term. If there's not a geneticist in the area, you could also refer to specific specialties. And then I really encourage testing for her brother, her niece, and her kids as well, to discuss the risks and know what their risks are for these cancers long term. So I always like to end on a note on direct-to-consumer genetic testing, just because this is a question I get asked a lot. People have done 23andMe, they've done Ancestry.com, they've done even some more of these more rare types of direct-to-consumer genetic testing that might tell you, what wines might taste the best to you. That's one I've seen, or they've done it for their dogs. I think these are great for people who are interested in ancestry or fun facts, and they're just curious folks. Where I get hesitant about these is when people start to think that they're clinical grade testing. And I do want to stress that these tests are not clinical grade tests, and they should not be used for health information. I also want you to be very cautious of third-party sites that offer to take the raw data that was collected during those kind of direct-to-consumer based genetic testings, and then they analyze it for you. We found that raw data actually has a very, very high false positive and false negative rate, just because essentially the quality of the reads, as we call it, or the quality of how much they're looking at those specific genetic variants are just not very high. They're not looking at enough for them to be a good quality. So we've seen a lot of these results be false positives, false negatives. So if you do them, have fun with them, but please, please, please don't use it for your genetic clinical based testing. So my final takeaways, hereditary cancer syndromes are really rare, but knowledge of one can potentially be helpful for you and your family. If you're concerned about your personal or family history, please talk to your doctor and ask for a referral to genetics, because as we just talked about, of course, these clinical-based genetic tests are way better than any type of direct-to-consumer genetic test we'd be recommending. All right. Thank you. This is a QR code for our prevention clinics. That's where our genetics clinics are a part of. But of course, I'm sure I've met some of you in our kidney multidisciplinary clinic, and I'm happy to take questions.
Thank you so much, Lauren. That was really fantastic. I love sort of the detective work aspect of trying to think about syndromic kidney cancer. And so thank you for presenting. We always call them cases, but it feels like a case. A couple questions for you. When patients do have mutations, are they involving all of the cells in the body or just certain cells in the body?
Yeah, so again, I focus on these germline genetic mutations, which are typically present in every single cell of your body. Now, it's not going to affect necessarily every single cell of your body because the expression of these genes is different from organ and system to another. So a lot of these genes that are associated with kidney cancers, they affect kidney cancer rates because the kidney uses them specifically, but it might not affect like the breast tissue because the breast tissue doesn't really use that gene for its protection, essentially.
Here's a great question. I think something we're seeing more and more. If you had genetic testing after, say, your original kidney cancer, and now you've developed a recurrence or a new kidney cancer, is there ever any indication to repeat your genetic testing?
Oh, possibly. So your genetics shouldn't change over your lifetime. So if we tested you for VHL, 10 years ago, we don't expect that VHL gene to have different findings most of the time. However, let's say, there's now genes like FLCN or Birdhock-Dubé that you were not tested for, and your history looks suspicious for those other things, then we do offer updated genetic testing to look at some of these more new conditions that we've learned about, more recently. So I would say if you had testing done and it's been a while, certainly consider meeting with us in genetics for an updated consultation.
This is a definition question. What does penetrance mean?
Yeah, so penetrance kind of refers to essentially the associated conditions or symptoms of a specific condition. And is everyone going to get those or not? The short answer is not everyone is going to have all of the different things we associate with each condition. So if we think of things like Birdhock-Dubé in that example, not everyone is going to have a lung collapse. Not everyone is actually going to get kidney cancer or colon cancer. It actually might be that majority of people with that genetic change don't receive those specific conditions or develop those cancers, which is great, but it can make it really tricky when we're looking at family trees, because you can certainly see people who are unaffected but they are carriers of the genetic condition.
Are there resources within the Fred Hutch Cancer Center for patients with syndromic kidney cancer?
Oh gosh, I'm not aware of any specific like handouts we have, but I would say that if you have questions, we have a lot of genetic counselors at the Hutch. We're very, very lucky. We have 10 of us now, so you can certainly ask for your doctor for a referral to genetics, and we can walk through your case individually. I always provide my patients with a copy of my note that's pretty specific and patient friendly, and then we can also pull specific resources for each of them depending on their DNA and their findings. Oh,
sorry. One question that I can quickly answer is about lung cysts. Lung cysts do look very different on an X-ray study than a small lung mass that we may be concerned is a metastasis. Those tend to be solid tumors. So lung cysts do look different. So Lauren, so if you are found to have a syndromic kidney cancer, when should you have your children tested? Does it depend on the syndrome?
It does depend on the syndrome. So in general, for most of these cancer syndromes, the risks happen in adulthood. So typically what I'm saying is, okay, when your kids hit 18, let's start that conversation. Let's have them meet with genetics. Let's figure out at what age do they want to be tested. And sometimes we do base it off of when does screening start. So if screening doesn't start till you're 40, do you want to know at 18? Or do you want to think about it maybe when you have your own kids? But I will say there's a couple exceptions. Some of these kidney cancer predisposition syndromes do have childhood onset risks. And so in those specific examples, I talk to patients, we refer them over to children's, and we say, okay, look, we have seen kidney cancer as young as 11, 14. So at around 11, we do recommend you go to children's and have your kids tested, or at least have the conversation about the pros and cons of getting them tested at that young age.
Does genetic testing test for damaged mitochondria?
Oh, no. So my testing, again, isn't going to look at damaged mitochondria. It's really, again, going to focus on those inherited types of genetic mutations that develop in the sperm and the egg. So it's not going to be looking at that.
And then this is a question I'm going to pose to Dr. Taikoti. I hope that's okay, Dr. Taikoti. So this is a question about cancer as a metabolic illness, a metabolic disease. What are your thoughts on the potential of metabolic therapies? So what do you talk to your patients about with respect to a ketogenic diet, for example, as adjuncts to standard kidney cancer treatment?
Many of the genes that are involved in increasing risk of kidney cancer that Lauren tests for are genes involved in the energy cycle, in terms of how cells metabolize nutrients to generate energy. So there is this narrative in kidney cancer about the impact of derangement of the normal pathways of energy metabolism. That being said, how to exploit that in a practical way and guide people in terms of lifestyle changes that impact their cancer, I would say there are not clear-cut guidelines or data out there that guide us. So we don't hand off any specific game plan or regimen to patients in terms of lifestyle changes, dietary changes. We do have nutrition services on campus, and we're happy to connect people to get a little bit more sophisticated discussion than your MD probably is prepared to bring to the table. But there isn't anything that's codified in terms of consensus guidelines and things that we try and make people aware of. So it's interesting biology, and it is intimate to what happens to cells that become kidney cancer cells. But sadly, as for so many intriguing areas of research, it doesn't translate into some hard and fast advice that we can hand over to patients.
And then one last question for you, Lauren. So if it's not approved by insurance, what does it cost out of pocket to have genetic testing, if you know?
Good question. So I want to say the coverage for genetic testing has gotten a lot better in recent years, just with the expanding guidelines. And so oftentimes we can get insurance to cover it, but in the scenarios where insurance does not cover it, there are a couple labs that offer $250 self-pay price. So that's a lot less than what they bill your insurance, but oftentimes we can get it for $250 for the patient. We also have patient assistance programs and other kind of genetic tests that we use sometimes for patients that are free. So again, chatting with us in genetics is kind of the best route for that, because we really have the knowledge about, okay, what tests are available to you, what is their cost, what does their coverage look like, etc.
Really wonderful. Thank you so much. Thank you for giving such a wonderful talk.
Yeah, thank you.
We are now going to transition to our break. So we're going to take about a 10-minute break. We'll plan to be back around, do you want to try to come back a little early, Dr. Taikoti?
My only fear is that the afternoon speakers might not be prepared to be available a little bit early. So let's have, I'll come back on about 10:40, but I think we'll probably kick off right at the 10:45 mark, just so we don't disrupt the expectations of the folks that need to be here in the afternoon. Some of our faculty that are calling in wouldn't necessarily know that we're trying to start a few minutes early. So we get an extra 5 minutes for break time, but 10:45 sharp restart, and we'll be online a couple minutes before to get ready. On my clock. So let's jump in and keep on schedule for the afternoon session. I encourage folks watching to go ahead and take advantage of the chat. We did have several questions in the morning session, but we did nicely on time. So if you have something in mind, certainly throw it out there and we'll try and address it. And again, not all of our speakers will be able to stay online for the entire length of the session. So if you hold it till the end of the day, you might be disappointed that a person you're hoping to answer is gone. So let me kick off our afternoon or our late morning session by welcoming Amy Marbow. Amy is the Director of Patient Programs for the Kidney Cancer Association, and talking on her session, Meet the Kidney Cancer Association. Amy.
Well, thank you, Dr. Tykody, Dr. Gore. Thanks for allowing the Kidney Cancer Association to speak to everyone this morning, this afternoon, wherever you are. It's great to be with you. I am the Director of Patient Programs at the KCA, and I am pleased to share with you a lot of our resources and information that might be helpful to patients and caregivers. So a little bit about the Kidney Cancer Association. It was founded in 1990 by Eugene Schoenfeld, a patient, and a small group of patients and doctors in Chicago. And we've grown today to be an international nonprofit organization. And we really focus on the 4 activities listed below: support and empower, research, educate, and advocate. So we support and empower patients and caregivers by providing a variety of resources. We help to fund research by providing grants to researchers who are looking to find new treatments for kidney cancer. We educate both providers, so doctors, nurse practitioners, physician assistants, nurses, anyone on your care team, as well as patients and caregivers about the latest in kidney cancer treatments and research. And finally, we help advocate to lawmakers about the needs of kidney cancer patients. So one program that we have that we are very proud of is our Patient Navigator program. That is Rosemary there on our screen. She is our patient liaison, and she is wonderful to talk to. So she helps to provide additional information about your kidney cancer diagnosis, about financial assistance programs that might be available, local support services, or help finding a kidney cancer specialist if you're not already seeing a physician at Fred Hutch or in your local or one in your local area. So this is a complement to the patient navigators or the nurses or social workers that might be at your cancer center. So Rosemary is a great addition to helping provide information should you need it anytime along your kidney cancer journey. We also have multiple educational programs and materials. One that I wanted to highlight for sure is our patient symposium, our virtual patient symposium. So it's a very similar setup, via Zoom that the Kidney Cancer Association hosts each year. This year it is September 9th. It will be from 8 a.m. to 1 p.m. Pacific. And on the right side of your screen, you see all of the topics that are being discussed. And I wanted to point out especially that the nutrition and kidney cancer session is being done by a dietitian from Fred Hutch, Ray Palco, who I've worked with before and has a wealth of knowledge. But we have a whole variety of topics, from understanding your pathology report, supportive care, hearing directly from patients and caregivers about their kidney cancer stories. So we're really proud of this symposium. And again, kind of a compliment to today's program. So at the end of this, I'll put links in the chat so you can sign up if you would like. We also have our Just Diagnosed Toolkit, which is our patient guide. So it's available both digital, so online, you can look at it in a PDF form, or printed as well. And we can mail you a printed copy free of charge for you and your family should you want to look at it in print form. Dr. Tykody and Dr. Gore, if you would like some to hand out to your patients in the cancer center, we would definitely be able to send some your way to provide to your patients. We also have so many other materials, so many other programs. We have a newly launched clinical trial finder, which takes information that is publicly available about any clinical trial in the country, and really makes it a little bit easier to understand, who might be eligible, where these trials are being held. And so that finder is available on our website. We have, I believe now over 100 short patient videos that answers, the most common questions that patients and caregivers ask. Those are answered by kidney cancer experts. And we also partnered with Triage Cancer. Some of you may know Triage Cancer. They help provide resources with respect to insurance and employment during cancer. And so Triage Cancer, together with them, we created some financial resources, your rights, during a kidney cancer diagnosis and work, understanding your insurance, things like that. With respect to support resources, we have many ways for people to be involved and to find and to share, support. So on our website, we have a virtual honor wall. You can share a tribute about a loved one, or you can let others know about your own kidney cancer journey by providing a little snippet about your experience. It was mentioned earlier, but we are also a big advocate for Smart Patients, that online community where you can post questions and you can respond to others' questions, really trying to build a sense of learning from peers. We offer 2 support groups each month, one specifically for patients and one specifically for caregivers. The patient one meets on the final Wednesday of each month at 5 p.m. Pacific, and the caregiver one meets on the last Tuesday at 4 p.m. Pacific. Those are drop-in. You can join, whenever works for you. You can join in our August one. We just had our July ones. You can join in August. You might need to skip September. You can join in October. So there's no need to join every single one, but if there's a time that you need support from others through conversation, resource sharing, things like that, we really encourage you to join our support groups. And finally, we have our mentor program. So this is new. This is brand new. You may be the first to know about this, but we are partnering with a national organization who does cancer peer mentoring. And so if you are looking to find support from someone who's been on this kidney cancer journey maybe longer than you, and or if you are wanting to share your experiences with someone who may be newly diagnosed, we will have more information about this in the coming weeks. So we're very excited about this peer mentoring opportunity. We also help to bring awareness. So Kidney Cancer Awareness Month, you may know, is in March here in the US. And one way that we bring awareness is to encourage people to have their cities lit up in orange for kidney cancer. That is something that you can do on your own. I'm not sure if anyone has ever lit up anything in the Seattle area. I did a little research beforehand, and I understand that the Seattle Great Wheel is sometimes lit up for awareness. So if that is something that someone would want to look into, please let us know. We can provide you some information on how you may be able to do that in your local area. We also have our 82K challenge, which is an awareness event that we host in June. We host that in June because June has World Kidney Cancer Day. 82K, 82,000, that number, it changes every year. And it's because this year in 2023, about 82,000 new people will be diagnosed with kidney cancer. And so just bringing awareness to the number of people who will be diagnosed this year. So you can get your family and friends, challenge them to do 82 things, or any increment of 82. So, walk for 82 minutes, or do the Stairmaster for 82 steps, just different ways to bring awareness to your friends and family about the number of people who will be diagnosed each year. You can become an ambassador of KCA. And what does that mean? There's a lot of ways to be involved, but one way, this lists 3 ways here. You can advocate to your legislators for more kidney cancer research funding that was talked about earlier. You can write a guest blog. You can work with our communications director to share your story, to share tips, tricks that you've learned on your kidney cancer journey. And you can also become a social media superstar if that's something you're interested in. You can post your story on your own social media pages and use the hashtags kidney cancer and then KCA's special hashtag unstoppable together. And we might repost you. Now you might be wondering to yourself, how can I possibly keep up with all of these activities and events that the KCA hosts throughout the year? You can sign up for our monthly newsletter, and I'll put that link in the chat here shortly. But that's a great way to keep updated with all the latest and greatest, sharing information for both patients and caregivers, as well as what might be happening in terms of research and what doctors are learning about and things like that. So lots of great information in the newsletter. So I just want to thank everyone again. Our website, kidneycancer.org, you can find us there. We're on all the social media, so Facebook, Instagram, Twitter, LinkedIn, I believe maybe TikTok. So lots of ways to find us. But thank you again to Dr. Tykody and Dr. Gore for allowing us to join you all today. And we look forward to seeing you at our next events.
Great. Thank you, Amy. That's a wonderful overview. I think in this day and age, making connections virtually is such a prominent thing. I'm probably not the best spokesmodel for social media. I have a question. If Ritu could comment quickly, several of the participants are asking, how will they collect and have all of the links to these different organizations after this seminar is over? Will that be emailed out, or will it be posted in some fashion that people can find sort of everything in one place?
So for now, we're just providing a link to the recording of this event. And so if speakers want their slides shared as part of that email, please let me know, and we can include that in the follow-up email that we send to registrants.
Okay, thank you. Okay, excellent. Our next speaker is Dina Battle. Dina is the co-founder and president of KC Cure, and presenting a talk for us, patient-driven evidence-based advocacy. Dina.
Hi, thank you so much for letting me be here today. Can you guys hear me okay? Okay,
Yes.
good. All right, I'm going to share my screen. Let's see if I get this right. I feel like I should be much better at this by now after doing Zoom all these years, but all right, perfect. So I thought I'd start out today by talking a little bit about our why. Why do we need patient-driven evidence-based advocacy? And these are statistics that most people know. 500,000 Americans living with kidney cancer, more than 80,000 will be diagnosed this year. The majority of patients, 78%, will be diagnosed with localized disease. And I think that's an area where, there's not a whole lot of education, not a lot of focus on localized disease. But, certainly many of those patients will recur. And then we have 20 to 30% who have metastatic disease. But what are their needs? What are important to those patients? See if I can make that go forward. So let's think about the history here. In 1992, we had our first drug approved for kidney cancer, high-dose IL-2. And look at how fast things had advanced. Today, we have 17 approved drugs, and that's amazing. But it also means that it's a lot of information for patients to think about, and the decisions are more complicated. Our survival rates are increasing dramatically. They've more than doubled since the 90s. But it also means that patients are living longer with their disease. They're going to be sequencing therapies. So it's more that they have to learn and know. And at the same time that that's happening, wait times for doctors. Getting an appointment, seeing a doctor is harder. This is the average wait time from a survey is 28 days for a new patient appointment. We know that this is something that patients really struggle with, is finding a specialist, but also getting in with that specialist. And then once you're there, you have less time. You know, the demands on the system. This was a study by the American Medical Association. They found that once patients were in with their doctor, the actual time that they spent talking about things was just 8.3 minutes. Now, I certainly don't think that's the case for most of the oncologists working here, but we all know that time is a little bit more strained than it was. And then we have really radical shifts in how information is found by patients and shared. We've gone from the age of written information to the internet, and now we have social media, and the majority of people accessing information on handheld devices. So it's really radically changed how we get information. And then we have really severe problems with information overload. A traditional Google search for kidney cancer will get you 160 million results. You know, it's kind of impossible to figure out what's relevant, what's accurate, what does this mean for me? So it's become much harder for patients to get the information and discern what's important. And then there's also a decrease in quality of information. 20 to 40% of the results that someone would get on their internet search are paid advertisements, which might not be a bad thing, but it makes people a little bit more skeptical. And a lot of people aren't really able to differentiate between what's paid, what's not. Things are outdated, change rapidly. A lot of patients are concerned about the fact that there's, information that says one thing simply because of a practice change that can be really distressing for patients. And then we have the rise of social media. It's really amazing how this has taken off. And social media has given great opportunities for patients to crowdsource, connect with other people, and that's really important. But it's also created new ways for misinformation and difficulty in understanding information I think that's something that it's just a new way of a new problem that we have to deal with. So this is from a survey that we did in 2017. Over 450 patients participated. And we asked two open-ended questions. We asked patients what frustrates you most about care. And these are the results we got. The most important thing was obviously fear of their cancer progressing or recurring, but also distrust of the cancer care system and lack of appropriate information. And then we asked them, if you could, what would you want to improve most? And the number one thing that patients said was greater understanding or compassion for their doctors, better access to information, and research to improve chances for a cure. And I think this was surprising when this information first came out. I think a lot of the doctors we presented it to were a little bit surprised. I don't think that patients really feel like there's a lack of compassion, but I do think there's disconnect and discord, and that can make it a little bit difficult. So putting all this together, kind of brings us to what we're trying to achieve as an advocacy organization. How can we help patients navigate today's medical journey and today's diagnosis with cancer? And these three pillars, patient outreach is really the center of everything that we do. And that's most important, because if we really want to be advocating for patients and we want to do it in an evidence-based way, we need to be connected with patients every single day. So our outreach is primarily focused on social media because that is where we know patients are going. We run 9 private communities. We have over 10,000 members, and we add 2 to 3 new members every single day. Research shows that these type of communities provide emotional support, increased psychosocial support, Also, it increases and enhances relationships with doctors, and it improves access to information. And this really gives us an opportunity to improve education and provide patient education materials directly within those groups, answering the questions that are most important to what patients are seeking. And then we also have provider outreach. So we're connected to cancer centers all over the country. I'm grateful to the doctors here who have been part of our scientific advisory board and who have been part of this outreach effort. Since we launched just 6 years ago, we've directly connected over 2,000 patients with RCC specialists. And that's a growing area where we hope to help with increased navigation. And then patient-driven research. We have a peer-reviewed competitive research grant program. And this allows patients to designate funding priorities that are specific to them. To date, we've raised over $600,000 and awarded either directly or scheduled to award. And just to kind of give an example of this research award, I think the most successful example I can give is patients in our chromophobe kidney cancer community reached out and said, why isn't there funding for chromophobe kidney cancer? They raised $50,000 in 1 year, and we launched a grant program. And within actually in the first year, that research funding doubled. So we now have three years funded for that program. But the award that the first award that went out to MSKCC, and that research has been so promising that we think there might actually be a chromophobe specific clinical trial launching in the next year or two. So to see that patient-driven effort really culminate in such a significant way for patients is really exciting. And we hope to have more of these type of, like I said, research priorities that aren't being funded through other areas, where patients really come together and say, we want research in this space. And then our patient-centered research. So since we launched, we've done 7 major surveys focused on patient preferences. We've had over 1,000 patients participate in these surveys. And this has allowed us to aggregate data and present at major medical conferences and present and publish in journals. And this is really, I think, changing providers' understanding of what is important and significant to patients. And I think ultimately, hopefully, will lead to better, improved patient-doctor communication, so we can sort of bridge those gaps and help in those areas where we know that there's definitely a need. So I'm going to stop there. This is our website, and you can also write down my email address. People can feel free to reach out to me directly if you have questions. And I think I went through that in pretty rapid time. I don't know if we have any time for questions or not, but I will stop sharing now.
Thank you, Gina. Yeah, that was excellent. I think the comments were just mainly supportive, and also, again, people hoping to have the proper links. If you have a moment, or perhaps Ritu could repost your email connection and webpage into the current chat for the time being. That's the best we can do. Thank you so much.
Thank you.
Very good. I see Dr. Rini online with us, and so I'm delighted to introduce our next speaker. That I certainly overlap with as a medical oncologist. Dr. Rini is certainly a nationally and internationally recognized expert in kidney cancer care. He is professor of medicine and chief of clinical trials at the Vanderbilt Ingram Cancer Center, Vanderbilt University in Nashville, Tennessee. He's been a leader for many years in the field, and senior investigator for several practice-changing clinical trials leading to FDA approvals. And I'm sure many in the audience have received therapies where Brian was the senior investigator. He wears many hats. For example, has been recently part of the guidance committee, ODAC, Oncology Drug Advisory Committee to the FDA. He has a highly popular podcast that he runs weekly, reaching out to the geo-oncology community. And so is widely recognized in our circles. And we're absolutely thrilled to have him here today to talk to us. Brian's talk, Systemic Therapy for Adjuvant Frontline and VHL-Associated Kidney Cancer. Brian.
Thanks, Scott. I'm having some Wi-Fi problems at home, so I'm going to need somebody to advance my slides. I apologize. I don't know what's going on. If somebody could do that, that would be great. So, oh, yeah, you can just go back to the first one, maybe. Thank you. Sorry about that. So I'm going to talk, thanks for the invitation. It's great to be here. I'm going to talk about sort of a big swath of kidney cancer, all the way from adjuvant through frontline. And then I'm going to end with von Hippel-Lindau disease, where a drug called belzutifan, a HIF inhibitor, has really revolutionized the disease. I just think it's kind of exciting. And so this will be, sort of a big picture overview. I hope it's useful. I've tried to sort of make the slides more patient friendly. We use a lot of acronyms and language, in academic medicine, some of which are useful, others not. But by all means, feel free to speak up if something I'm saying isn't clear. You can go to the next slide, please. So when we talk about kidney cancer, when I'm approaching a usually frontline metastatic kidney cancer patient, I say, hey, listen, there's two main categories of drug that we use. One is immune therapy, which is represented on this slide that I'll go through in a minute. And the other is anti-angiogenic, anti-blood vessel, anti-VEGF therapy, or TKIs. It has a bunch of different names, and I have a separate mechanism slide later on when I get to metastatic. And those are by and large the two main buckets of therapy that we have in kidney cancer. And we need more, but for now, that's what we have. This is a slide that depicts basically tumor immunity, tumor T-cell immunity in one slide. So we know from decades of work that the way the body recognizes a foreign substance, in this case, that foreign substance could be a cancer cell or a protein part of a cancer cell called an antigen, is that it's presented on the surface of various type cells. That would be the cell on the bottom there. Those are often called dendritic cells. There's other cells, including the tumor cell itself, that can present antigens. And then the T cell on the top is the functional arm of the immune system. That's what attacks and kills tumors. But in order for that T cell to be educated and then to be revved up, it needs the presentation of that antigen. And so sort of on the left in between the cells there, you see that antigen being presented, and those green, the green circles with the plus in it means those are signals that stimulate the T cell. But we also know that there's signals that serve to dampen the immune response. And the reason our bodies are designed this way is that if we didn't, we would all have rampant autoimmune diseases. Our immune systems would be revved up against all of our organs and every single foreign substance in our body. So it's kind of the yin and the yang, the brake and the accelerator, if you will, of the immune response. So for years, the positive signals have been known. And then maybe, 15 to 20 years ago, I think was when the work started to realize that, as you see in the middle of the slide, CTLA-4 and PD-1 are sort of the negative regulators of the immune system, those red circles. So now in the boxes, you see names of drugs that in essence inhibit this inhibition. So they remove the brakes. CTLA-4 and PD-1 are natural brakes on the immune system, on the T cell response. And so if you can release those brakes, you can unleash, if you will, a patient's natural anti-tumor immunity. There are PD-1 inhibitors, commonly nivolumab and pembrolizumab are used in RCC. There are PD-L1 inhibitors, which you can see act a little differently. In kidney cancer, they've not been as active, and I won't really talk about them. That's not true in all diseases, but in RCC. And in the middle white box, you see CTLA-4 inhibitors. Ipilimumab is the one that's used in RCC, which also release the brakes, but do so by attacking a different protein. And so this is the basic mechanism of how immune therapy works. Next slide, please. So I'm first going to talk about adjuvant therapy. So the history of adjuvant therapy in kidney cancer is basically that nothing really worked to reduce the risk of recurrence. When I see a patient who has a resected kidney mass, so they do not have metastatic disease, they have a resected kidney mass, the two questions are, what is the risk of recurrence, and can we do anything to lower that risk? And for years up until this study, the short story is we really didn't have any way to reliably lower that risk of recurrence. So patients would do nothing, get periodic scans, and in essence, keep their fingers crossed that they didn't have recurrence, which many patients don't, but unfortunately, a percentage of patients do, probably 30% or so of all patients who have a resected kidney mass. Then came the immune therapy era, and this study, which was called Keynote 564, and you can see that box, that eligibility criteria means who was allowed to enter the trial. So these were patients that were deemed at higher risk for recurrence of kidney cancer. Why were they high risk? They had bigger tumors. They had higher grade tumors. Grade is sort of how ugly the cells look under the microscope, and certain other features. And based on those features, patients were deemed to have probably at least a 30% risk of recurrence up to probably a 70 or 80% risk of recurrence. Those patients underwent surgery. They were then randomized to a year of pembrolizumab in the adjuvant setting. Adjuvant just means after surgery, or placebo infusion. And then, of course, all patients were followed to look at, what happened over time. Did one group have recurrence earlier than the next? Next slide. So this is the different groups that were entered into the trial. They broke it down into the intermediate, high, and then the resected metastatic disease. And actually, advance again. Yeah. So what I'm trying to show here is that when we see patients have different risks of recurrences, right? So a patient with a smaller tumor, sort of in that left-hand column where it says 31%. So that's the lowest risk that was entered in this trial. So about 3 out of 10 patients would have recurrence, 7 out of 10 would not for those features. And then as you go from left to right and tumors get bigger or the grade gets higher or there's involvement of lymph nodes, that risk of recurrence goes up. And the reason I put these numbers, because that's the first part of the equation. Hey, doc, what's my chance of this cancer coming back? And remember, for any one patient, we can only estimate it. We don't have any good tools to know whether a patient's going to be in that 30% who have recurrence or in the 70% who won't. We'd be a whole lot smarter in applying therapy and advising patients if we did. But at present, we do not have those tools. And then I'm going to show you data on the next slide that shows that a year of adjuvant immune therapy lowers that risk. It lowers it by about 35% on a relative basis. But the second row in my table is the absolute risk reduction, because that's, I think, what patients relate to. So I have, again, focusing on that 31%. I have a 31% risk of recurrence over the next 5 years. This drug, if I get it, can help me reduce that risk by 10%. And therefore, I have a 21% risk of recurrence. I lower it from 30 to 20. And then each patient, I think, with those numbers can make a decision. Gee, I think it's worth getting a year of therapy, and I'll talk about side effects. Or you know what? That's a lot of therapy and a lot of potential side effects, and that risk reduction isn't that much. As an individual patient's risk of recurrence goes up, the absolute reduction does as well, right? The higher risk you are to recur, the more you stand to benefit from therapy because you're more likely to recur, right? We can't help patients who don't have cancer, right? If patients aren't destined to recur, we can give them all the drug in the world. It's not going to help them, of course, and they don't need it. All right, next slide. So when we look at adjuvant studies, we look at what's called disease-free survival. From the day of entering the study, how long did a patient live without recurrence of disease as based on a scan, usually? So that's disease-free survival. And there was just 2 analyses presented. That's the left and the right hand. If you just focus on the right hand, because it's the more mature data, you see what we're going to look at a lot of these Kaplan-Meier curves. And so ideally, what we'd want for every drug in every situation is a line going straight across the top, an absolutely horizontal line that goes straight across the top, right? That would mean no patients recurred over time. That's not the case, of course. And you see that at that 2-year mark, about 78% of patients did not recur who got adjuvant therapy, and about 68% did not recur who got placebo. So most patients in both arms didn't, but significantly more didn't recur, about 10%. At that 2-year mark. You'll also see on my slides this HR. HR is hazard ratio, and it's basically a way of looking not just at that one point in time, like 2 years, but the whole curve. So what a hazard ratio tells you is that at any point in time, up until these curves go out about 3 years, that a patient who got adjuvant immune therapy had about a 37% less risk of recurring. So you take 1 minus the hazard ratio, it's about a 37% less risk of recurring. I find that, I don't know that patients relate as well to those numbers, nor do docs, by the way. So often just sort of looking at the landmarks and saying, yeah, we can, you have about a 10% less likelihood of recurring. Again, this is for the whole population, notwithstanding my previous slide comments about patients in different risk groups. So this was significant. P-value usually less than 0.05 means it's not due to chance, it's actually a real result. And these were the data that led to FDA approval of this drug a year plus ago. Go to the next slide. So this is getting into the weeds a little bit, but there's if you look at kidney cancer cells under the microscope, there's a growth pattern that's called sarcomatoid. It's not sarcoma, which is a separate tumor, but it's sarcomatoid, meaning the cells are shaped like sarcoma cells, even though they're absolutely kidney cancer cells. And what it is a certain pattern that unfortunately tends to be more aggressive, but fortunately tends to be more responsive to immune therapy. And so this is just showing that in that subset of patients, the benefit of a year of adjuvant immune therapy was even more beneficial. And that's on the right there. Again, you can see those curves are more separated than the curves on the left. And I bring this up because this is one thing I do use in clinic. If I have a patient who, maybe they're on the lower end of risk based on the size and the grade, and I'm deciding, how strongly I want to recommend therapy. If they have sarcomatoid features, and that's something that would be in a pathology report, then I might lean more towards giving that therapy. Next slide. This is overall survival. So everything I presented was disease-free survival, right? How long until a patient has recurrence of disease? Overall survival is, of course, how long do patients live, right? Which at the end of the day is what we're trying to do, not just prevent recurrence, but make patients live longer. This study has not yet shown an overall survival benefit. So when I'm sitting with patients, I cannot say to them, gee, I know by getting a year of adjuvant immune therapy, I'm going to make you live longer. I know that on average, I will reduce the risk of recurrence, but I can't say with confidence yet, and this may change over time. I can't say that I know that I make them live longer. And I don't find that this factors into too many patients' decision, but it's important, right? If all we're doing is delaying the recurrence and we're not preventing it and not making people live longer, we might think differently about getting that therapy. Next slide. Really busy slide. I apologize. This is just the safety results. This tends to be how we present it. I put in bold, sort of in the middle bottom half, what I thought was important. So AEs are adverse events, this whole laundry list of things that we ask patients about. So grade 3 is generally considered serious, grade 3 or higher. So that's why it says grade 3, 4. You could see about 20% of patients had serious adverse reaction to getting the immune therapy. So again, nothing's free, right? So any good therapy we have is going to have side effects. What I usually tell people is that 8 out of 10 people will tolerate this drug just fine. They might have minor side effects like an itchy rash or some loose stools or thyroid problems. But most people tolerate it fine. But if you're in that 10 or 20% that has serious side effects, which can also be permanent, lifelong side effects like thyroid dysfunction, then quite obviously, that is important. There were no deaths in this study from adjuvant immune therapy, but that's certainly possible. It's not at all likely, but it absolutely is possible. This pembrolizumab can cause inflammation of the heart or lungs, which is very rare, but very serious and sometimes fatal. So, as more patients get treated, it's very possible that there will be patient deaths. And again, that's, in this setting, when you're not even sure a patient's going to recur, it's something that can give you pause. And then the very bottom number down there, that 7.8%, those are patients who required high dose steroids. So when immune therapy works, it stimulates the immune system to fight cancer, but when it causes side effects, it stimulates the immune system to attack normal organs like skin and gut and liver. And when that happens and it's serious, then we give what's called high dose steroids. So prednisone at say 40 or 60 milligrams or more. So not quite 1 out of 10 patients had such serious side effects that they require those high doses of steroids. Generally not a big deal, but again, just a marker of the subset of patients that can get more serious side effects. Next slide. So I've told you about the trial on the top left that led to FDA approval of pembrolizumab, this adjuvant immune therapy. But late last year at a meeting called ESMO, which is a European cancer meeting, there were 3 other trials with similar drugs that were negative. So if you look at the lines in the top left box, those split, right? Patients who got drug did better, right? We want that line to be as high as possible. But if you look at the other lines, you don't need to be a statistician to say that all those patients are doing the same, regardless of whether they got therapy. So those 3 trials were what we would call negative. They did not show a benefit. And if you just advance one, it'll pop up, I hope. Thank you. So why were the others negative, right? Why would only one be positive? We generally expect things to trend the same way. Well, atezolizumab, which was the trial in the top right where the box is, I mentioned this previously, that's a PD-L1 inhibitor, so it acts out in a little bit different spot in the immune system. And generally those drugs are less active in kidney cancer. So that's the prevailing sentiment as to why that trial was negative. Click again. That trial in the bottom left, it was a trial done in the US cooperative group system, not by a drug company. And without getting into the weeds, it had a lot of problems with study conduct. A lot of patients did not get the intended therapy. And of course, if you don't give patients the intended therapy, of course, they're not going to benefit. And then next, one more click. So the bottom right is a regimen called Ipi-Nivo. So that's 2 drugs. And I'll talk more about that in a second in the advanced setting. But that was also studied in this setting. And it's a fairly toxic regimen. And one theory anyway is that toxicity in this setting, which is different than the advanced setting, limited drug delivery. But honestly, this is the hardest one to explain. We know it's active. It's a really good regimen. And I don't have a great answer of why it didn't produce benefit in this setting. So this one, I think the field is still scratching their heads about. But I think it is important when I'm talking about adjuvant therapy or when a patient's listening to know that you want to give them all the data, right? And a patient may look at this and say, well, gee, it's, 75% of the trials were negative. It was only 1 positive, and that might influence their decision to get therapy, one way or the other. Next trial. So how do I give adjuvant immune therapy? I see a lot of these patients from my urologist. One thing to remember, and I tell this to patients, is their risk of recurrence isn't 30%, it's 100 or 0, right? They're either destined to recur or not. So again, if we assume about 30% of patients will have recurrence, that means 70% won't, and we can only harm those patients, right? I can't make a patient who's not destined to recur any better by giving them therapy. So for me, it just gives me a little bit of pause to use adjuvant pembro in this setting. I do offer it, but as the second bullet point says, I tend to offer it to patients who are on the upper half of that risk. So call it 40, 50% risk of recurrence or higher, not those down towards the 30%. And then of course, I talk about toxicity in the negative trials, and I have a very low threshold to stop therapy. For instance, a patient goes on therapy and 3 doses in, their kidney function worsens, or they have some problem. I just have a low threshold because I'm really worried that, boy, I'm hurting this patient more than I'm helping them. So every doc approaches it differently. It's not right or wrong. This is how I do it. And I would say about, 50 or 60% of the patients that are sent to me for adjuvant pembrolizumab will receive it. Okay, I think next slide, I think that's the end of adjuvant therapy. I'm going to turn towards metastatic therapy if you go to the next slide. So this is a very old slide, and it basically shows those 10 lines this was a big group of kidney cancer patients and sort of looked at how they did over time. This slide is probably 25 years old. So it's before the era of all these new drugs that I'll talk about. So it's kind of like what we would call the natural history. What happens to patients over time? And it's really meant to show that it's, as the title says, that kidney cancer is very biologically diverse. And as physicians, we need to remember that as we're approaching patients, it's not one disease, it's many different diseases. Some unfortunately very aggressive and some very indolent, and everywhere in between. Next slide. So I bring that up because before I talk about drugs, I want to talk about not treating patients or observation or active surveillance, it's also called. We did a trial years ago that looked at patients who have kind of very slow growing kidney cancer. So as an example, a patient had their kidney cut out 8 years ago. 18 months ago, some small lung nodules were noted, but it wasn't clear what it was. 12 months ago, those nodules were maybe a little bigger. 6 months ago, a little bigger still. And now they're sitting in my office and it's pretty clear that this is recurrent kidney cancer and maybe you biopsy to prove it. That's not an uncommon patient that I see in my clinic. And those patients, in essence, they've already been observed for 18 to 24 months, right? You just didn't know it. You didn't know you were observing metastatic disease until it played out over time. And this was just an attempt to do a trial to sort of define the numbers. So probably the most important number is sort of smack dab in the middle, that observation time of 14.9 months. So in this selected group of patients, we watched them for well over a year before we started treatment. And there's some of the data numbers on the right there, but It really just says that, again, you need to account for biology when you're approaching patients. We have lots of drugs now. There's something like 14 or 15 FDA approved drugs. But I would say maybe 1 out of 10 or 15% of patients, I will initially just observe them. It may also depend on their age and other health problems, et cetera. But it's not that they're too sick to get treatment usually. It's just that I don't think they need it yet. And so I always sort of throw this in when I'm talking about drugs, because we can't sort of forget that not giving drugs is okay in select patients as well. Next slide. Before I talk about sort of the results, I want to talk about what we call IMDC prognostic criteria. So this stands for International Metastatic Database Consortium. That's a mouthful, so we just say IMDC. This is a big collection of kidney cancer patients' data. It's about 20,000 patients now. On the bottom right, you see Hang, the name Hang there. That's Danny Hang, who is in Canada, who's actually my fellow in Cleveland Clinic 100 years ago. And he developed these criteria by looking at all these patients and saying, gee, which patients do well over time and which patients do less well. And on the left, you see the factors, and these are the adverse risk factors, which, so patients who have more of these adverse risk factors tend to do worse over time. KPS, is performance status, which is kind of a measure of how fit is somebody. And then the other ones are fairly quantitative. The bottom 4 being lab values, and LLN is lower limit of normal and ULN is upper limit of normal. So if you have labs that are outside the normal range, those specific labs, those are adverse criteria. And anyway, it's important to know this because we talk about it a lot. I think we probably talk about it too much. But if you're looking at data and your doc this would be something that they might calculate in clinic. And it's important, I think it's most important, not because it should determine the therapy you get, but because people want to know prognosis, right? I mean, certainly on day 1, that's a very common question. Hey doc, what's going to happen here? And although you don't know sitting with that patient on day 1, if they're going to respond to therapy and how long they're going to respond, and there's all sorts of things you don't know. You can use these criteria to say, well, gee, an average patient like yourself, here's how they do. And I think that's, usually helpful for patients. I think that's the most proper use of these criteria. Next slide. So I showed you the immune therapy schema before. This is the schema for the other type of therapy we have. So to talk a little bit about kidney cancer biology, most clear cell kidney cancer patients have inactivation of a specific gene that's called VHL, or von Hippel-Lindau. My last slides, I'm going to talk about patients who inherit a von Hippel-Lindau gene abnormality. So they have inherited kidney cancer called von Hippel-Lindau syndrome. But even if it's not inherited, most clear cell kidney cancer tumors have this same mutation. That mutation causes, if you just look at the red circle, accumulation of this factor called VEGF, vascular endothelial growth factor. And as the name implies, it's a growth factor for blood vessels, right? So genetic mutation causes blood vessel growth. Well, then it stands to reason if we can block that factor, i.e. block VEGF, we can block tumor growth and tumor formation. And so there are many, many different ways to block VEGF. If you go to the next slide, I don't remember what I have. Actually, back up one, I'm sorry. That's too confusing. There are many different ways to block VEGF, most commonly with what we call TKIs, tyrosine kinase inhibitors, sunitinib, sorafenib, pazopanib, lenvatinib. Anything that ends in IV in our world is a small molecule that blocks VEGF. And most commonly, they're called TKIs. And there are other ways to do it, but not terribly relevant here. So that next slide I'm about to show you includes that class of drugs. And that's why I want to just introduce, how they work. These are working on blood vessels. I often describe them to patients as anti-blood vessel drugs. Next slide. Apologies for the busy slide, but since I don't have time to talk about, each trial in detail. In kidney cancer, when I started training, which was late 90s, early 2000s, were right about when those TKIs developed. Sunitinib and sorafenib were the first ones, and patients got us one of those drugs, and then they got another one, and then they often got a third one. Now we give patients 2 drugs up front because now immune therapy has developed. So the 4 columns here are the 4 FDA-approved standard ways to treat initial advanced kidney cancer. That first column of numbers is the 2 immune drugs. One inhibits one of the proteins called CTLA-4, the other inhibits PD-1. And I put in parentheses IOIO So IO means like immune oncology, and it's a slang that we use to say an IO drug is an immune stimulating drug. And people specifically refer to this regimen as IO-IO. And then the other three columns are just different permutations of adding one of those anti-blood vessel drugs and one of the immune drugs. Why are there three different ones? Because there's a whole lot of drug companies out there and they each want to get their drugs approved. And that's why these various combinations come about. It's for no other reason, but they're not all the same. And I'm not going to go into the differences here, but what this slide is just showing you is, and again, it's probably not the best way to display the data for this group, but it's showing you they all extend overall survival compared to just getting one of the anti-blood vessel pills. And that if you look sort of in the middle where it says ORR, that's response rate. So how many patients have significant tumor shrinkage? And as you see, it's 40, 60, 60, 70. So most patients now I can say confidently to most patients that by giving you one of these regimens, and again, I'm not going to go into why you give one versus the other, I have a pretty good chance of controlling your disease. So very few patients will progress right through and have their first scan be worse. Most patients will have some sort of response, and that response on average lasts about 2 years. So we're in a much better position to at least control disease now and potentially control disease for a long time than we were before these combinations came about. But we would call these an IO-based doublet, right? An immune oncology-based doublet. They all have at least one immune drug. One has two, the others just have one and one other drug, but an IO-based doublet is sort of the slang for what we say is standard of care. Next slide. Oh, sorry, go through. I forgot I had animation. Give me a couple clicks. Yeah, just go through. I'm going to make these points. There we go. I mentioned sarcomatoid histology when I talked about adjuvant pembrolizumab as a marker. And guess what? It's a marker for immune responsiveness with these other regimens as well. So this is data from that Ipi-Nivo trial, so 2 immune drugs. And it's really just showing that if patients have this feature in their tumor, this growth pattern, that they respond even better to this all-immune regimen. And I have it there as the best biomarker. A biomarker is something that allows you to select a certain therapy for a certain patient. And so I use this to select this particular regimen for advanced kidney cancer patients. Next slide. And this is just a summary slide. I mentioned IO-IO. The other 3 columns in that busy table were IO-TKI, right? So it's one immune drug and one anti-blood vessel drug. And these are the things that in our nerdy kidney cancer circles, we debate all the time of, I like this regimen, I like that regimen, et cetera. And they all have their pros and cons that I'm listing for you here. I'm happy to talk in more detail, but it's really just a summary slide to say no regimen is perfect. They all have things that, that they do well and then have other limitations. And again, I won't go through these in detail, but at the end of the day, although we debate in academic circles, maybe which one we like the best, they're all perfectly FDA approved and appropriate for initial treatment of kidney cancer. Next slide. All right, so we're oncologists. We love giving drugs. If we give one drug, we want to give 2. If we give 2, we want to give 3. So I just said 2 drugs are the standard of care in kidney cancer, but you can imagine then the natural question is, well, gee, why don't we give 3 and see if we can do even better? We're just starting to do that in kidney cancer. The first trial that looked at that was called Cosmic. It's represented here. Initial advanced kidney cancer getting either that all-immune combination that's on the bottom in the blue of Ipi-Nivo with a placebo pill, or get that same double immune therapy, but now add in one of those TKIs, Cabo or cabozantinib. And so it makes all the sense in the world, right? Instead of debating which 2 regimen is best, let's just give them all, and maybe we can benefit more patients. Next slide. So it did show what's called the PFS, or progression-free survival. So how long do patients live without their disease getting worse? It did show what I would consider a small advantage in progression-free survival, did not improve overall survival. And if you go to the next slide, it was toxic. So, not surprisingly, the more drugs you give, the more toxic the regimen is. And if you actually just look at that far right column, I mentioned high-dose steroid use in the adjuvant Pembro trial was 7.8%. In this trial, it was 58%, right? And high-dose steroids are not fun. If any of you have been on them, not to mention the side effect isn't fun. Being on loads of steroids is not fun. And so it's really just a marker of toxicity. So again, a very toxic regimen. I have the title being limited drug delivery, and I'm not presenting those numbers, but if you're making patients sick, it's hard to treat them, right? It's hard to get the drug in. And if you don't get the drug in, guess what? Patients can't benefit. So the story of this trial was a good first attempt, a little bit of activity, but a whole lot of toxicity. So this regimen won't go anywhere, it won't get FDA approved, et cetera. But there are other trials looking at other triplets. So the triplet story isn't done. It's just this first trial didn't pan out. Next slide. Yeah, and this is an example of one of those other trials. This is a Merck trial. It's actually almost 1,600 patients. It's completed accrual. And so now we're just sort of waiting to see what happens, but probably in the next, I don't know, 18 to 24 months, we'll have results. And I think we're heading towards a day where some triple drug regimen is the standard of care. Whether it'll be something on the screen or some other trial, I don't know, but I think we're probably headed there. Next slide. So just to summarize frontline therapy, I tend to use IO-TKI. It's easier to give. I can give it to pretty much anybody who walks in my clinic, but, and I didn't really talk about this too much, the responses tend to be a little less durable because you have one immune drug, not two. Ipi-Nivo is a great regimen. If you respond to it, you tend to respond for a long time, but it's more toxic. That's that Ipi-related toxicity. It tends to be more toxic, and it doesn't control disease as well up front for most patients. I think about tolerability. So the TKIs are easy in that they're pills, but they just wear people out over time. And I have in parentheses there, breaks are okay. So every single one of my patients on TKIs long-term takes breaks. They take 3 or 4 days off every 3 weeks, 4 weeks, 6 weeks. You know, they're going to Europe for a week. Great, take the whole week off. You know, there's nothing wrong with taking breaks, and it really recharges the batteries. And we have no idea whether we need to give these pills every day, or we just have no idea. They're not studied that way, but I can tell you from many, many years of experience, taking breaks from your pills are okay. Ipi-Nivo, as I mentioned, is tougher up front, but once you get through the first about 12 weeks of that regimen, it's actually probably easier. So again, it's just the balance of, you know, pluses and minuses for each regimen. Ideally, we could just give immune therapy, like a single immune therapy drug by itself, but we don't know which patients we can do that, and the trials that have tried to do that have largely failed. I didn't talk about biomarkers, but we desperately need a way to choose the best therapy for a particular patient. And then I mentioned triplets. I think we'll get there, but the initial attempt wasn't successful. Next slide. Oh, and this is just a timeline slide that I usually put in the beginning, but I thought it fit best here. So I did fellowship, 1998 to 2001. So at that point, high-dose interleukin-2, which we haven't talked about, which is sort of an old immune therapy, was the only FDA-approved drug. And then as I started my first faculty job, which was losing track of my years, 2001, you see 2005, that's when these TKIs started to be developed, that TKI era, so to speak. And individual drugs, each of them, you know, could shrink tumors, but they weren't curative. Then immune therapy in the last 10 years came in, and now we're into what I'm calling here the IO combo era, which I just described. And you could see the average survival has increased dramatically, you know, 5-fold, right? It's not long enough for sure, but it's dramatically better than it used to be as a result of all the drugs you see on the screen. Next slide. All right, I'm just going to finish up with VHL or von Hippel-Lindau syndrome. As I mentioned, non-inherited kidney cancer, and the vast majority of kidney cancer is not inherited. The clear cell variety of that has a mutation in this gene. The tumor has a mutation. In patients with VHL syndrome, all their cells have this mutation. So it's a syndrome. If you go to the next slide, I think it shows it graphically. It's a syndrome basically with those 7 features. And I think of it as a syndrome with vascular tumors. So number 5, obviously, is, you know, kidney cancers. That's what we'll talk about. But it's not just kidney cancer, it's all these other things. And if you see number 3 there, hemangioblastomas are these blood vessel tumors that in these patients occur in the brain and spine. And they're devastating from the standpoint of getting repeated surgeries on your brain and spine is quite obviously quite morbid. So probably number 3 and 5 on this list are most prominent. Again, there are other diseases, but it's not just in one organ, right? Inherited syndromes are in multiple organs because the genetic abnormality is present in all cells. Next slide. So this is that same graphic I showed you before, but instead of highlighting the VEGF, now I'm highlighting HIF. So HIF stands for hypoxia inducible factor. And as the name implies, it's a factor, a protein that gets gets increased when there is hypoxia. So in all our bodies, when there's hypoxia, meaning low oxygen, if you go climb Mount Everest, that's hypoxia, right? So if you did that, your HIF2 alpha levels would increase. Well, in kidney cancer, the cell thinks that it's in a hypoxic state because of that mutation. And so that particular protein gets upregulated. And one of the things it does is increase that VEGF protein. That's just normal kidney cancer biology. In patients with VHL syndrome, that happens even more. And the next few slides, I'm going to talk about a drug called belzutifan, which inhibits that specific protein. So it's not inhibiting VEGF down below. It's working, we would say, upstream in that HIF protein. And it's really, it's an amazing story. You know, people, for a variety of reasons. Anyway, the Nobel Prize was just awarded in part based on this. So that tells you that it's pretty important. So next slide. So patients who have von Hippel-Lindau syndrome can get up hundreds of tumors in their kidney, again, as one manifestation. Well, in the old days, which was about 2 years ago, in the old days, you would watch those patients and you can't just keep cutting out the tumors, right? You're going to cut out their whole kidneys. So urologists would say, well, let's just watch them. And when a tumor gets to 3 centimeters, then we'll cut it out. And that 3 centimeters came from some very old data, but it was generally accepted, called the 3 centimeter rule. So then along came this drug belzutifan, and if it's going to work in anybody, it's going to work in patients who have a genetic mutation that increases the level of the protein that the drug inhibits, right? So if this drug has any activity, it better have it in this setting. So this was a study done, you see, in just over 60 patients who had inherited von Hippel-Lindau syndrome, and they had at least 1 kidney lesion. And then they were given this drug, that MK is an old name for it. They were given this drug and then obviously watched, you know, subsequently with scans, et cetera. Next slide. And if you look at the right hand, so we haven't looked at, this is called a waterfall graph. Each one of those vertical bars is an individual patient. And the longer the bar, the farther it goes below that 0 line, the more the tumor shrank, right? So ideally, all those bars would go down to 100. Well, of course, that never happens with any drug, but this is as impressive of a waterfall graph as you'll ever see. Nobody had tumor growth, right? Not a single patient as their best response had tumor growth. And most of the patients had significant amounts of shrinkage. Some of the numbers on the left are just the ways we sort of chop up patient responses into different categories, but I think the right side is more visual and more impressive, actually. And if you go to the next slide, it's my favorite graphic from this. So this is looking at data in a different way. So each of the horizontal lines are an individual patient. And then the blue dots are where they had procedures. So they had a urologist go in and cut something out. That's a blue dot. Sometimes patients will get tumors burned or frozen. That's a blue dot. So anytime an individual patient needed something done, they got a blue dot along their line. And you can see, to the left of that vertical line in the middle where it says 0 down at the bottom, there's a whole lot of procedures. And that's just what this disease is, right? It's repeated procedures on kidneys and brains and spinal cords. Is terrible. But then if you look to the right of that line 0, which is when the drug started, you see very few, like 3, right? I mean, it's amazing, right? The reducing the number of very morbid procedures that patients need. And that's quite obviously because their tumors got smaller, right? If tumors are getting smaller, not bigger, then you don't need to go in and do anything. You don't need to go do these procedures. So really impressive data. You can see it was published in the New England Journal of Medicine, which is sort of the high watermark for our industry, and really impressive. And again, I think it's completely revolutionized this disease. Next slide. I'm not sure what else I have. Oh, this is really just to say that it wasn't just the kidney tumors that shrank. Again, ORR, that line at the top, is response rate. What percent of tumors shrank significantly? And you can see, 80 or 90% of these pancreatic tumors, and even 30% of the central nervous system tumors, CNS. And these numbers have gone up over time. And again, so it's not just acting in the kidneys, it acts everywhere that this syndrome affects, quite impressively. So next slide. And again, busy slide, but really this is just to say that it's a really well-tolerated drug. And now I have VHL patients who've probably been on it for years. We participated in these trials. So it's a drug that can be taken for a really long time. I mentioned that TKIs are really tough to take for a long time. This drug is much easier, causes some anemia, some fatigue, a little bit of swelling, but some relatively minor things, but generally a well-tolerated drug. Next slide. And that's it. So just to wrap up everything, adjuvant pembrolizumab as immune therapy is a standard of care for resected kidney cancer at high risk of coming back. We don't have a great way to select patients, like who's actually going to recur and who's not. So sarcomatoid histology I mentioned, but it's imperfect. And the other immune trials, they failed for different reasons. And it did color my opinion of pembrolizumab, but it certainly didn't make me stop using it. In advanced disease, giving what I called IO-based doublets, so one immune drug plus another drug, is the standard of care. We don't have a biomarker in that setting either. And how your doc chooses depends on a whole lot of things, including the doc's bias, right? I was involved with certain trials and not others. So guess what? I kind of like those regimens better, in part because I know them better, right? And I know how to give the drugs better, and that's perfectly reasonable. And then lastly, as I mentioned, belzutifan, I think Welireg is the brand name. It's really revolutionized VHL patients. It's a whole lot of fun taking care of these patients now because instead of sending them for morbid procedures, you're giving them a well-tolerated drug and they're doing quite well over time. So I'm happy to take any questions. Thanks for your attention.
Thank you, Brian. That was a wonderful overview. One question in the chat box, a patient asking if you have any brief comments on your approach to non-clear cell patients.
Yeah, so non-clear cell, which is probably a good, 10, maybe even 20% of kidney cancer patients. Historically, unfortunately, we develop drugs in clear cell and then we apply them, we give them to non-clear cell patients because we don't know what else to do. And they're generally active, but not as active in clear cell. I will say, and this is credit to industry in the last, 5-ish years, we're doing a much better job of doing dedicated trials in non-clear cell, of recognizing that term non-clear cell isn't one disease, it's at least 3 or 4 different diseases. So what is the activity of a drug or regimen, each of those subsets of non-clear cell? So I think we're studying it better, but it's also, it's a small subset of a rare disease, so it's really hard to study. And to answer the question, I give those patients an IO-based doublet. And there's not large randomized trials to show benefit, but there's some small, what we would call phase 2, 50, 60 patient trials that show pretty good response rates and drug activity. So I give them, a regimen like one of the 3 columns of the IO TKIs that I mentioned.
Great. One more question before we move on, I think also is a wonderful question. So for a clear cell kidney cancer patient that has brain metastases, how does the brain involvement influence your care ideas?
Yeah, so when patients have brain involvement in central nervous system, we would say those patients, in my opinion, need local therapy. And by local, I mean either having those brain metastases cut out or much more commonly now focused radiation to the brain mets, which is usually called SBRT, stereotactic body radiotherapy. There's a lot of different terms for SBRT. It's all the same. It's all focused radiation just to the spot. Very effective at controlling those brain metastases, over 90% effective in the areas that get radiated. So I would do that first, and then I would put them honestly on whatever regimen I would otherwise. I don't pick a certain regimen for that kind of patient and a different regimen for another patient generally. I don't know that there's great rationale for that. So, they have the added, significant wrinkle that they need their brain disease addressed first and then go on systemic therapy.
Great. Brian, thank you so much. We're so pleased you could join us today and be our keynote speaker. So
yeah, thank you. Sorry about the technical problems.
No worries. We got it to work.
All right, take care.
Thank you. All right, excellent. So our next speaker, we've already heard from this morning. Our co-host, Dr. Gore, is going to talk to us next about new techniques for minimally invasive surgery for kidney cancer. John.
Thank you so much, Dr. Tykody. I'm going to share my screen. I'm here to show some cool videos, but I do want to talk about some new technologies that we're using to do kidney cancer surgery. And I know that Dr. Lowe after me is going to talk about new technologies for ablative management of kidney cancer. So I think these will marry really well. I do like to kind of talk briefly about how we designate the different stages of kidney cancer. I know we've represented this in a couple of different ways, but as has been mentioned a couple times this morning, most patients with kidney cancer present with localized kidney cancer. And localized kidney cancer tends to be fairly algorithmic, meaning that Smaller tumors, we tend to steer patients toward trying to save as much kidney as we can and thinking about either a partial nephrectomy or some kind of ablative technique where you're killing the cancer by freezing it or burning it or radiating it. And then for larger kidney tumors, we usually have to take out the whole kidney. Sometimes that kidney tumor can be locally advanced and it's a more complicated surgery that involves some vascular surgery or other organs around the kidney. But I want to focus mostly today not on these larger tumors that can be locally advanced or even these tumors with a complex vascular thrombosis. This is meant mainly to illustrate how unbelievably heterogeneous kidney cancer can be, or even tumors where we can do a minimally invasive nephrectomy. I want to focus on these smaller tumors, the tumors that are amenable to potentially saving as much kidney as we can. And sometimes we even see tumors like this that are essentially like a backpack growing on the outer edge of the kidney. So this is sort of a decision tree that I often walk patients through in my clinic. And those of you who are listening in, who've seen me in clinic before, I always talk about how we're going to make our decisions. And one of the first decisions is, do we need to do something about this tumor or not? One really important management strategy for kidney tumors is surveillance. And so oftentimes for smaller tumors, akin to what Dr. Rini talked about for metastatic disease, we'll watch it. And you'll hear me say that we need to make this tumor prove to us that we need to do something about it. But when we do need to intervene, the first question we need to ask ourselves is this something where we can spare some of the kidney? And that NSS stands for nephron sparing surgery. Or is this something where the whole kidney has to come out? And that's a radical nephrectomy. And that's a much more important decision than what technique or what technology can we use. It's really just based on the anatomy of the tumor. And then the second question is, can we do minimally invasive surgery where we're using small incisions and telescopic instruments? Or is this something that requires something more invasive, like with an open surgery? And then last but not least, and this is sort of technical mumbo jumbo, but is this something where we have to go through the front and do this through the abdominal cavity? Or is this something where we can go through the back and create an artificial space behind the kidney? And that's called a retroperitoneal approach to the kidney. So what is a partial nephrectomy? Well, a partial nephrectomy is recommended by our guidelines as the preferred approach for tumors that are less than 4 centimeters. The stage that we assign those tumors is a tumor stage 1A. It's not always anatomically feasible. There are occasions where someone has a small tumor, but it's just smack dab in the middle of the kidney. And in those cases, even though it's small, we still have to take out the whole kidney. But really, cancer control is the priority here. So if we feel like for whatever reason, even though it's a small tumor, cancer control could be compromised by doing a partial nephrectomy, then it's not the right thing to do. In general, the benefit of this is that it maximizes your long-term kidney function, and that could, in theory, be associated with better cardiovascular outcomes. So by helping someone keep as much kidney as possible, we help their general health as well. This was some work that I was a part of, gosh, a long time ago now. It doesn't seem like it, but we were able to show using some national administrative data that patients with small tumors who had a partial nephrectomy versus a radical nephrectomy had better survival outcomes. And the thought is that, that by maintaining as much kidney as possible, decreasing the risk of chronic kidney disease, that this is associated with better cardiovascular outcomes. So it's not that this demonstrates better cancer outcomes, it's better overall general health outcomes. So what is a robotic partial nephrectomy? So the robot is a tool, just like any other tool that we have in the operating room, but it's a way to increase the use of making small incisions and doing minimally invasive surgery for some of these complex renal masses. And the reason is the robot allows 7 degrees of freedom in motion. So it allows you to have wrist-like motion. as opposed to standard laparoscopic surgery, which only has 4 degrees of motion, where you're essentially using these stick tools in the abdomen. So when you're trying to cut out a spheroid tumor or sew up a complicated defect in the kidney, that wrist-like motion is really beneficial. And so this really does allow us to replicate everything that we do open in a minimally invasive approach to kidney surgery. And as I've gotten older and more gray-haired, the occasions where we're using open surgery have decreased quite a bit over time. So this is a great example of a fantastic indication for a retroperitoneal approach to the kidney. This is a patient that has a right colon urinary pouch. So what that means is their bladder has been removed for some other health condition. And because the bladder has an important function, the urine has to go somewhere. So the surgeon created a urinary pouch out of the colon, but lo and behold, that urinary pouch is sitting right in front of the kidney that has a new kidney tumor. Well, what we can do is we can create an artificial space behind the kidney back here and completely avoid the area where this colon pouch existed. So it's a way to be safe, avoid, prior surgical areas, but still do an excellent cancer surgery. And this shows you, how, even with a complex midline scar, and that patient almost certainly has intensive adhesions in their abdomen, we can put instruments in, outside of the cavity where the intestines are and get directly on the kidney. The other thing that this allows us to do is approach tumors that otherwise would be really, really hard to get to. So this arrow is showing you a tumor for orientation. We're looking at sort of the midpoint of the kidney. This is showing you a tumor that's right where the blood vessels are going into and out of the kidney. And so if we were trying to get to this through the front, that would be a really challenging thing to do because you essentially need to go all the way around the kidney to the back side of the kidney. But by going into this artificial space behind the kidney, we can find ourselves essentially right on this tumor and see it in a much safer way and do almost an easier surgery than we would do as an open approach. And this just shows you how we get into this space. So what you see here is you see that this space here, and this is a space between the abdominal wall and the kidney, has been ballooned apart. This is not usually a normal opening. So it's not usually a space that has a lot of natural space. So we had to use a balloon to create it. And we're putting in instruments into this space. And this is kind of where the kidney is located. And this white line that you see at the top is the line of the abdominal wall cavity. So now we have to move that line out of the way to get additional instruments in. And so you can see here, using a small kind of Q-tip, we're pushing that line to basically give us even more space. And that's going to allow us to put some additional instruments into the abdomen. So as we create more and more space, moving more and more toward the abdominal cavity, that allows us to take this space that doesn't normally exist and do a complex surgery in that artificial space. And so you can see here, we're putting in some additional instruments in that area. Oh, sorry. Okay, so now this shows you what we do when we do this. So what we're doing is we're approaching the kidney from the backside. So the anatomy when we do this is just very different. We're not looking at the intestines. And so what we're trying to do here is we're trying to get into the space underneath the kidney. And so I'm opening some tissue layers that allow me to find the muscle, and you can see that beefy red muscle that allowed me to find the muscle behind the kidney. And then I'm able to just lift up the fat underneath the kidney and march my way into where we're going to identify the blood vessels to and from the kidney. And we can use some additional tools that help us out. So that was a tool called Firefly, where we give the patient an injection of a dye called isocyanine green. And that dye will illuminate where the artery is. And you can see here the artery shining as a bright green tube. And so that just shows me where the artery is located, so that if I have any concerns or I'm worried about localization, I can use that as an adjunct, and that helps me be safer. And you can see now we're just trying to create some space around the artery because we want to pinch that off so that when we cut into the kidney, we can do a safe job. So after we do that, now we want to think about, can we be safer? Can modern technology allow us easier access into these complex spaces? And I think about those spaces from the front or from the back. So what are the challenges we have going in from the front? Well, one of the big challenges we have in 2023 is the challenge of prior surgeries. And it used to be when I was, a younger individual, that if someone had a complex history of prior operations, that was a reason to default to an open operation, where now we're making a big incision and imposing upon that patient a bigger recovery. But if we're just trying to get one instrument in, that might allow us to navigate the scar tissue that some patients have and be a little bit safer. So what I'm going to talk about just for the rest of this discussion is a new technology called the single port, or SP robot. So traditional robotic surgery has involved putting individual ports in, and through that one port goes one instrument. So in the original robot, you had 3 total instruments, 1 camera and 2 working instruments, so essentially a right and a left hand. In more contemporary robots, you have 4 instruments, so 1 camera and then 3 working instruments, and then you can toggle one of those that allows you to retract for yourself and do some complex dissections. But that involves making 4 different incisions in addition to an incision for your assistant. So for example, when we do a partial nephrectomy, we have someone passing sutures in and out of the abdomen, and that is requiring an additional or a 5th port for an assistant to help us out, or to put in a sucker device to suck away, any small amount of bleeding or other things that are in the way of us doing our dissection. Well, with this single port, you can see that through one hole, it's a little bit bigger, it's about 1 inch as opposed to about 1 centimeter. Through one hole, you can deploy 4 instruments concurrently into an abdominal or belly space. And so instead of making 4 or 5 incisions, now we can make 1 or 2. And so for a complex space like the retroperitoneum, instead of having to try to figure out how to create this space, we can just put this one instrument in, and lo and behold, we're right on our target. So I'm going to show you a short video that shows you how we can use this single port robot. And you'll notice right away that the instruments are a little different. But what you can see are 2 working instruments, and I'm doing the same thing. I'm trying to get in this artificial space underneath the kidney and find the muscle that sits right behind. And then here, I'm going to find the artery that takes blood to and from the kidney, and I'm going to create some space around that artery so that I can put a clamp on it and safely cut into the substance of the kidney. And there you'll see it right there. It's this whitish tubular structure right there, kind of emerges in our view. And now we're going to clean off the area of the kidney, and the kidney is always this really pretty kind of pink purple color, but you can see the angry tumor sitting like a pimple on the outside of the kidney. So it's the more yellowish discolored structure. And what we're going to do is just create some space around the tumor. And this is just using all instruments through one single incision. So it's just a way to be more efficient and more targeted and give the patient only 1 or 2 incisions to go home with. So we're just creating some working space around the tumor. And then even when we see it as discreetly as we see this tumor in our view, we still always insert an ultrasound device because we want to confirm that where we're going to cut into the kidney, we're going to cut into normal kidney tissue. And that's what gives us a healthy margin of tissue around the tumor. So you can see me putting a little ultrasound device in. And now what we've done is we've clamped the artery and we're going to cut into the kidney. Now the instruments are a little different. When you have these 4 fiber optic cable driven instruments, they aren't as strong as the other robots, but you can see that for a small kidney mass, this works really well. And there's a contrast here between the normal kidney tissue, which still looks kind of purplish, and then the tissue that we're rolling away that contains the tumor. And we can see that nice, healthy kidney tissue all the way underneath, which tells us that we're taking a healthy margin of tissue around this kidney tumor. And so we're just going to disconnect the last little tether that this tumor is holding to the kidney. And you can see it's a really patient thing that we're doing. We're not trying to hurry. You know, I always tell our residents that you save time by taking time. And that's it. And now there's this defect in the kidney that we're going to put some sutures in to sew closed. And this is a fairly small defect, so it only took about 3 stitches, but you can see that it just pinches closed and coaps really beautifully. And so this SP robot is a really nice way for us to continue to manage increasingly complex kidney tumors with minimally invasive surgery. And it's part of our goal to maximize 3 really important interests when we're thinking about doing these surgeries. Number 1, just being safety. One thing that compromises safety when someone's had multiple prior surgeries is that scar tissue in their abdomen can yield a higher risk of unintentional injury to other structures around the kidney, one of the most common ones being, for example, the intestines. But if we're just trying to create a very small space and get a 1-inch instrument into the abdomen, that actually allows us to be more safe. Priority number 2 is doing excellent cancer surgery. So if we thought that using this 1-inch single port robot compromised our ability to do cancer surgery, we wouldn't use it. And so I will say that there are a number of cases that I think have a much greater complexity than that video I showed you, where I make sure that when I'm booking the surgery that I'm not using the single port robot, I'm using a different robot that maybe has stronger instruments and a better ability to show me the areas, because I can't just focus on instruments right around the area where I'm doing surgery. But it also really facilitates our access to these small confined areas. The ability to do these surgeries through this artificial space behind the kidney dramatically increases our access to tumors on the backside of the kidney that traditionally, even with an open incision, were very hard to reach. And so it's a way that the new technologies that are being developed has really enabled us to do, safe, complex cancer surgery and continue to prioritize quality of life and recovery for our patients who require kidney cancer operations. And I'm happy to take any questions.
Thanks, John. It's always fascinating to see, the images from the operating theater. Very interesting. Let's see in the chat. A patient asking you that when you're either suturing the kidney for partial or taking out the whole kidney, how long does it take to seal closed? Is there a risk of tearing?
So in general, we don't leave the operating room if there's any concern about bleeding. But like any part of the body, like the skin incision or like the strength layers that we have to close, there is a healing process. So for example, we often treat these surgeries like there's been a trauma to the kidney. And so we'll often have patients stay on bed rest overnight, just basically like staying in bed and not going for walks to avoid any perturbation to the kidney that might stir up bleeding. But usually by about 2 weeks, we feel pretty good, like we're out of the window where we're worried about what we would call a delayed bleed, where despite things looking perfect in the operating room, some scab could fall off or some blood vessel could bleed that could lead to a delayed complication. That fortunately is pretty darn rare. One thing I didn't include in this talk, but since we have a couple minutes, is just briefly discussing the changing role of surgery for a lot of the patients that Dr. Rini mentioned, which is what we call cytoreductive nephrectomy. So that's the idea of taking out the main tumor or taking out the kidney in someone who does have metastatic disease. Back when Dr. Taikoti and I started working together, that was sort of the default, where before we would start someone on, an intravenous treatment for their kidney cancer, we would take out their kidney first. And now we know that just really kind of delays what patients really need. That if they have cancer in multiple parts of their body, they need treatment to multiple parts of their body. And so they need Dr. Taikoti before they need me. And so now it's more of an individualized decision where we figure out how the medications we're using are working, and whether or not taking someone's kidney out has an important role in their overall kidney cancer care. So we still do it quite a bit, but it's in a more selective situation. But just like with a partial nephrectomy, in those cases, when it's feasible, we try to prioritize minimally invasive surgery.
John, as you're showing some of your images, patients that had interesting complicating features for managing a small renal mass, can you put some round numbers? So when you talk to a patient and you think it's a target that likely can be managed by minimally invasive techniques, but what's the likelihood that you have to convert it to a full-on open surgery once you're in there? And so what are the odds the patient wakes up and they have a much larger
bigger
incision
scar
than they thought on the way into the OR?
Yeah, pretty low. When I was a younger man, and you knew me then, Dr. Taikoti, I would always put on the permission form, that we're going to do a robotic partial nephrectomy, but it's possible we'll have to make an open incision, or it's possible we'll have to take out the whole kidney. And now our ability to specifically understand the anatomy of the kidney based on the CT scans that we have available, which are truly informative insight into the anatomy around the tumor and around the kidney, the plan is almost always the plan. So I would say on only 2 occasions that I can think of, have I had to make an open incision, and those were cases where we were doing reoperative surgery. So someone where we had done surgery on the kidney and we're going back and doing an additional surgery on the kidney, and we're trying to do it robotically, but it just wasn't safe. And I can only think of 2 occasions where we had to take out the whole kidney, where we planned a partial nephrectomy. And again, these were cases where we were kind of extending the boundaries of what we consider, a true candidate for it. And we ended up having to take out the whole kidney. So it used to be much more of a concern, but I think now we're able to so specifically understand the anatomy of the kidney from their imaging that the plan is almost always the plan.
Interesting. John, one question I have for you: a lot of patients that I see are broadly familiar with options for managing a kidney tumor, ablation or surgery or radiation. But I mean, how do you look at those options and strike a hierarchy about what you'd recommend to the patient?
So there are a number of considerations that we think about. That's a really great question. And I think if you asked, 5 of my colleagues in urologic oncology, you might get some different answers about how they think about this. I do think that the availability of robotic surgery changed a lot of our approach to this. So for example, even back in the 2010s, I would do surgery where we would free up the kidney and then with laparoscopic guidance, stick a needle in a tumor and freeze it. So we're doing the work of exposing the kidney laparoscopically, but still doing an ablative surgery. And now because of the increased technical ability of robotic surgery, I don't really do that anymore, because if we're going to do all that work, we might as well just cut out the tumor. And so the things that kind of weigh into our decision making are, number one, the risk of local recurrence with a partial nephrectomy versus an ablative technique. So with a partial nephrectomy, that risk is about 2 to 3%. And with an ablative technique, it's somewhere from 10 to 15%, depending on the size of the tumor and what its actual biology is. And so in general, for a younger individual, I'm almost always going to default to a partial nephrectomy. There are other considerations though. So, we spent some time talking this morning about syndromic kidney cancer, and sometimes, someone has a tumor and they've already had 1 or 2 surgeries on that kidney, and you worry that each time going back, because of the scarring that's going to be around the kidney, that there's a higher risk of potentially losing that kidney because of that scarring. And sometimes ablation, even in a younger individual, is a really great option for those cases. I think things about ablation that are really important to know is our radiology colleagues do a tremendous job of targeting these tumors. And so when we do send people for ablation, we're really confident in its potential benefit.
Thanks. We're right on time. We're hearing that Dr. Lowe,
Oh, there he is.
I was just going to say, is having some technical challenges. But I think we're happy to see him pop in here. So very good. Well, thank you, John. And again, I'm always fascinated by the videos and the actual pictures of the operating theater. As John and I share a lot of patient care for the kidney cancer population, so does our next speaker, Dr. Simon Lowe. That's probably been a treating provider for many of the patients that are listening today. Dr. Lowe is a colleague in our radiation oncology department, a professor in that department, an adjunct professor with the neurological surgery department. And here today to talk to us, the title of his talk, Radiation Therapy for Localized Kidney Cancer. Simon, take it away. Simon, you're still muted.
Yeah. Sorry, I have to utilize some help to navigate through the slides because I have a home internet outage. I'm using my cell phone to give the presentation right now. Okay, so I can start. So today I'm going to talk about the role of radiation therapy for primary renal cell carcinoma, or we call it kidney cancer, in layman's term. So this is my disclosure. So after the lecture, one should be able to discuss the role of radiotherapy in primary kidney cancer, discuss the side effects of stereotactic body radiation therapy, which is actually the main technique used to treat primary kidney cancer and their management, and to discuss the follow-up plan after radiation therapy for kidney cancer. Okay, next slide. So I'm sure that Dr. Gore did discuss about small renal masses. Basically, those are like incidentally discovered kidney masses on scans. So for the American Urological Association guidelines, active surveillance usually is used as the initial management for small renal masses smaller than 2 cm size. And it is recommended when the anticipated risk of intervention or anything that is done is versus the competing risk of death is higher than the potential oncologic benefits of active treatment. In that case, active surveillance or watching or observation would be recommended. Also, if the patient does not want to undergo an intervention, I think active surveillance can be used to manage small renal masses. And if the oncologic benefits of intervention is less, and if active surveillance is only given when patient is, if the oncologic benefits of any treatment would outweigh the toxicities of the treatment, but the patient doesn't want to undergo any intervention and is willing to accept the risk of oncologic progression, then is one of the options. And for ASCO, which is the American Society for Clinical Oncology, which is like the largest oncologic society in the world, the absolute indication for active surveillance is if there's a high risk for anesthesia and intervention, or life expectancy less than 5 years. And relative indications include significant risk of end-stage renal disease if treated, and small renal mass less than 1 cm, or life expectancy less than 10 years. So this is a diagram showing the different options, for small renal mass and large renal mass. The options include active surveillance, focal therapy, including cryotherapy or radioactive frequency, which is heat treatment, partial resection of the kidney or total resection of the kidney. And the new modality is radiation therapy called stereotactic body radiation therapy, or it's called SBRT, or outside of the US, like in Canada, Australia, and Europe, they call it a SABR, stereotactic ablative radiotherapy. Basically, it's the same thing. It's just a different name. So first, I would want to make it clear that I think, for any patients with kidney cancer needing focal therapy for treatment, surgery is still the standard of care if it is feasible, if it is deemed to be safe, and if it is not gonna result in kidney failure. But I think when you look at different options, not every patient is suitable for surgery or ablative therapy like cryotherapy or radiofrequency ablation. And when you look at the chart for comparison, of course, it's really not a head-to-head comparison because there's some scenarios that absolutely patients may have no other local options. So for partial nephrectomy, of course, general anesthesia will be needed, but for probe-based therapy like cryotherapy or radiofrequency ablation, anesthesia, general anesthesia won't be needed. And for radiation therapy, general anesthesia won't be needed. And, for tumors close to the hilum, hilum means the center part of the kidney. Oh, by the way, can you move the slide to the next slide? Okay, yeah. So this is the diagram. So for perihilar tumors, that means tumors close to the center of the kidney. You see the ureter is coming out. That's the hilum of the kidney. And if the tumor is close to the hilum of the kidney, which is the center part of the kidney, surgery is still feasible, but one cannot do the cryotherapy, which means the freezing therapy, or the heat therapy, which is the RFA, because number one is it will be less effective because the blood vessels there, would carry the heat or the freeze away, from the tumor, making it less effective. Number two, there's also a risk of damage, to the structures in that area. But for radiation, it is feasible, for us to deliver radiation to tumors located close to the hilum. And for large tumors, again, if it is too large, using heat or freeze, it won't be as effective because the heat or the freeze won't be reaching, the outer part of the tumor, so it would be less effective. But for surgery, of course, it's feasible. And for radiation, it's also possible for us to treat the big tumors. And in terms of how invasive it is, of course, partial nephrectomy, cryotherapy, which is the freeze therapy, RFA, which is the heat therapy, they are more invasive compared to radiation. But once again, I have to emphasize that, the standard treatment is still, like open surgery. I mean, a partial nephrectomy or nephrectomy for primary kidney cancer. And radiation is only appropriate for patients, usually not suitable for any of those options. So now I'm going to explain to you what radiation therapy is. So there are different types of radiation modality, radiation beams, photons, which is high energy X-rays, electrons, which is like the particles, radioactive particles, or protons, which is like heavier particles, which is basically hydrogen ions, or heavy particles, utilizing carbon ions or other heavy ions like helium ions. But the radiation we use to treat kidney cancer is actually photons, which means a high energy X-rays. So the mechanism of cell kill by radiation is shown in this diagram in general. So cancer cells, they have a DNA, which is a genetic material. And with radiation therapy, there are two mechanisms of killing, of the cancer cells. So we can either generate what we call free radicals, in the in the upper part of the slide on the right hand panel, you see generates like the free radicals, which is, you can see that it's indicated by like the OH, with the that molecule right there is the free radical, and that can actually destroy the DNA stranded genetic material. And in the right hand panel, the lower part of the curve, you see that sometimes the radiation actually can directly damage the DNA strand or the genetic material. So there are two mechanisms. So for X-ray treatments, typically about 2/3 of the killing occurs using the indirect mechanism. That means through the generation of free radicals. That's the reason why, for patients getting radiation therapy, typically we discourage them to take any high concentration of antioxidant, because they can actually mop up the molecule that is killing the genetic material of the cancer. Next slide. So historically, there are challenges with the use of radiation of kidney cancer because, number one, the kidney itself has a low tolerance radiation, and the kidneys move with respiration. So it's really difficult to target it if it's moving. And kidney cancer is very resistant to radiation, and a very high dose is needed to kill the kidney cancer cells. And also lacking in the technology to deliver focused radiation to the target precisely, it was a major issue. But with the recent development of modern technology, right now we're able to deliver precisely an ultra high dose of radiation with a very good local anti-tumor efficacy comparable to that of surgery. And it has been observed in other tumor types, like lung cancer or kidney cancer. I know what I meant was lung cancer and liver cancer. And preclinical and clinical evidence shows that kidney cancer is actually sensitive to very aggressive type of radiation, or ablative doses of radiation, with tumor control rates approaching 90%. And high radiation dose seem to have some immunogenic effect in some patients with renal cell cancer, and that may explain the some effects we see with kidney cancer patients. Some tumors, when this type of radiation is combined with immunotherapy, it can actually generate response more than what we expect under normal circumstances. So this is a diagram showing how it works. So, with high-tech treatment, actually, we're able to, number one, precisely locate, where we need to treat. And also, with respect to the radiation, with the respiration, I can go to the next slide so you can show the diagram. That's right, I'm looking at my computer, so I was, oblivious to the fact that, the slide that is being shown in the symposium is not progressing. So when you actually look at the diagram on the left hand, in the left hand panel, you can see that multiple radiation beams are cross-firing at the target. That's the site where we deliver the high dose radiation. So you can see that the red is the high dose region, and the green area is the intermediate dose region. And you can see the blue shades. Those are individual beams, and the blue actually is the blue areas are the low dose region. So although there are several areas, with low dose exposure, but all the high dose regions are located in tumors. So therefore, the low dose regions are not too damaging to the normal organs. But using this technique, using multiple beams cross firing at the site where the tumor is, one can deliver a high dose and not harming the surrounding structures like the stomach, the opposite. So I think patient selection is really, really important. Not everybody, should be getting this. So patients who are poor or high risk surgical candidates, due to OH or other concurrent diseases, like many patients, they got like multiple other diseases that would put them at high surgical risk. Those patients would potentially be suitable for radiation. And patients who have tumors exceeding the size for radiofrequency ablation or cryotherapy, which is free therapy, and who are not suitable for open surgery, those patients may be candidates. And patients who have tumors close to the hilum, which is the center of the kidney where the blood vessels and the ureter are located, those patients may be candidates for radiation. And of course, patients who refuse surgery, even if they are candidates, for surgery or like ablation, if they refuse those procedures, radiation therapy can be an alternative therapy for the patient. So in terms of treatment recommendation, I think it's really important. I have to emphasize that multidisciplinary team discussion is really important. So the team would consist of urologists, medical oncologists, interventional radiologists, and radiation oncologists. And we have to take into account the patient's general medical condition. And also we need to estimate the kidney function that would remain after treatment. And also patient's preference is also very important. So typically the workup, like before we determine, what recommendation we would make would include, like we need to, screen for like metastatic disease. And we also need to know of course, the full extent of the kidney tumor. So we will recommend a CT of the chest, abdomen, and pelvis with and without dye, and blood work, including renal function tests to see, what the renal function is like. And also, can you actually proceed to the next slide? I'm so sorry. Yeah, so next slide. So for the workup, as I mentioned before, CT of the chest, abdomen, and pelvis, and then blood work, including kidney function tests, so we know how much kidney function the patient has, and we can also estimate how much kidney function the patient will have after treatment. So in cases where the patient has marginal kidney function, we may perform a nuclear medicine kidney scan to determine the relative kidney function for both kidneys, because the thing is, if all of the kidney function is coming from the kidney with the kidney cancer, then we have to take that into account, whether any local treatment would be beneficial for the patient. And the patient in some cases may need an MRI of the abdomen, particularly, we cannot outline the extent of the kidney tumor very clearly on the CT scan. So for the treatment setup, it would involve what we call CT simulation, which is called a mapping session. So we'll put the patient under a CT scanner, obtaining a specialized CT scan, so we can outline the areas we want to treat. We can map out all the organs at risk for injury by radiation, and then we obtain a shape, and then we plan out that scan. And the patient usually would be put in an immobilization device, so the patient wouldn't be moving around, because this is a highly precise treatment. So to be precise, we need the patient to be really still. And we also have respiratory motion control strategies. So it would either be like there would be a plate compressing on the belly, the abdomen, so to limit the motion of the kidney tumor. And sometimes we use what we call the active breath hold. A breathing control. That means, we may need the patient to do a breath hold during the time when the radiation beam is on, so we can minimize the amount of tissue being treated. If the tumor is pretty still, we can treat a small area, and yet we'll be able to cover the whole tumor without missing the tumor. And we perform planning of the radiation using a computer, designing the beams, making sure that we fulfill all the goals of the treatment, including how much is being given to different organs and how much coverage we give to the tumor. And then we do a quality assurance to make sure that what we calculate on the computer would be exactly at least over 90% match with the actual dose being delivered to the patient. And then when everything is ready, we'll put the patient on the table for treatment. And before the treatment, we verify to make sure that the set of everything is correct before we switch on the beam, and we do that every day. And then treatment delivery. So this is a diagram showing the process. So on the far left, you can see that this is the CT simulation. The patient is put in the treatment device while the CT scan is being done. And then we'll perform treatment planning. The second picture from the left, you can see that this is the radiation plan, treating the kidney tumor while trying to spare the normal structures. And then, after everything is done, the planning and the quality assurance, then, the third picture from the left, you can see that we verify the setup before we treat. We make sure that everything matches. We typically won't tolerate anything more than 3 mm deviation. And then treatment delivery. So you can see on the far right, the picture shows that what the radiation is being delivered, there would be an abdominal compression plate limiting the motion of the kidney, and the radiation beam will be delivered. So in terms of side effects, I think this is very important for patients and caretakers to know. So we divide side effects into 2 groups, early side effects and late side effects. So early side effects occur during and shortly after radiation. So it could be fatigue. I think the patient may have skin redness, flank pain, nausea and vomiting, particularly if some beams are going through the stomach. So there's some way to tackle that. I'll go over that in the next slide. Abdominal discomfort and diarrhea, although it's rare, it can happen. And in very, very rare circumstances, because the kidney tumor is very vascular, it's very rich in blood supply. Sometimes, it can bleed spontaneously into itself. And sometimes after the radiation, there's a very, very rare chance it may bleed into itself. And the presentation would be like abdominal pain, and also, patient is feeling generally unwell, may have a shock due to the bleeding. And for late side effects, which occurs months and years after the treatment, include a decreased kidney function. And that's the reason why we need to estimate, the remaining kidney function after the treatment. And sometimes we need to do the nuclear medicine kidney scan to look at the relative function for each kidney before we decide on what to do. Permanent skin changes usually is in the form of tanning of the skin locally, and permanent injury to the stomach and bowels, which is extremely rare. I've never seen that before, but we always have to warn patients of the possibility. Decreased liver function, extremely, extremely rare, because the liver is a vast organ, and the kidney tumor, typically the relative size of the kidney tumor to the liver is very small. So we usually anticipate a very small amount of radiation exposure to the kidney to the liver in general. So management of the side effects from treatment, nausea and vomiting, so we can give anti-nausea medication. If it is the result of some beams going through the stomach, we typically would ask patients to take some anti-nausea, anti-vomiting medication that's 30 minutes to 1 hour before the radiation. Typically that could take care of the problem. And flank pain, Tylenol or other pain medications, other NSAIDs. And abdominal discomfort and diarrhea, usually Imodium or other anti-diarrheal medications will do the job. For skin reaction, skincare products as recommended by the treating team, but we seldom see skin reaction too much because the kidney is relatively deep in terms of the location, so the skin dose typically is quite low in general. So let me show you some of the research results. So this is one of the trials that were performed at a university hospitals in Cleveland, Case Western Reserve University, and I was one of the investigators. So they actually escalated the dose to using 3 sessions to the highest level, and actually they did not show any significant toxicities. And actually, when you look at the local control in 5 years, is around 90%, which is actually pretty promising. And you can see the survival curve. I think, a lot of times, a lot of those patients actually did not die of the cancer, but they actually die of their concurrent medical conditions, because all these patients that were included were patients who are not suitable for any other local therapy. They have a very low performance status, or have multiple medical conditions at the same time. That's the reason why they were not eligible for any other local treatment. So this is another study actually pulling all the patients from all around the world, through the International Consortium for Kidney Cancer Radiosurgery, and it included the patients treated in Germany, Australia, United States, Canada, and Japan. And there were 223 patients. It's the largest series in the world. And the tumor control in 5 years, as you can see here, is over 90%. Actually, it's over 95%, which is pretty promising. And once again, in this study, we saw a very low percentage of serious toxicities. I think low-grade toxicities, low-grade side effects are quite common, but not so much for serious toxicities, long-term toxicities. And actually, based on this study, the Ministry of Health of Japan approved SBRT for primary kidney cancer for the 125 million citizens in Japan on April 1st, 2018. So it's regarded as one of the standard treatment in Japan right now. So when you look at a kidney function, interestingly, some patients who got treated, actually, they got improved kidney function. We just can't explain why. But most of them, did have some decrease in the function, but not bad enough to require dialysis. So the mean decrease in the estimated kidney function was around 5.5 ml per minute. Sorry, I'm talking sharp, corresponding to an increase in the serum creatinine of 28.1 micromole per liter. And there was no difference in mean kidney function based on the size of the tumor. There was no difference in the mean kidney function change between patients who received different regimens. And within the entire cohort, I think actually 1/4 of the patients actually had improved kidney function after treatment. I just didn't know why that happened. We could not explain it, but that's the observation. So this is just a summary of the local control is 97.2% in general, across all the studies. And in terms of the severe side effects, is on a range of a few percent, which is very low. So last year, the consortium published long-term outcomes. That means, with each patient, at the very least, would have 2 years of follow-up, but the median follow-up is 5 years. So long-term follow-up. It was published in Lancet Oncology. So the 5-year local control is 90, the cancer-specific survival. That means patients, those patients who did not, die from cancer, so 92% at 5 years. And for local control is 94.5%, which is actually very high at 5 years. And in terms of the decrease in the kidney function, again, there's some decrease amount of patients, but actually very, very few patients actually ended up in dialysis. So in terms of follow-up, the optimal post-treatment follow-up schedule for treatment after radiation include cross-sectional imaging, usually the CT scan of the abdomen, including both kidneys, and adrenals every 6 months, as well as surveillance scans, including chest imaging at a minimum. So a routine post-treatment biopsy should not be performed to evaluate response. It's only recommended, and it's only recommended in patients with imaging findings concerning for disease progression. Next slide. So this is an example of a patient treated with radiation. On the left-hand panel was before treatment. You can see the kidney tumor. You can see something, like the kidneys are right, like a lateral to the spine. And on the far left, you can see an organ which is whitish in color toward the bottom of the figure. And there's a shadow which is gray in color. That's the tumor cell. And after 8 months after treatment, there was a tumor shrinkage, which is shown on the right-hand panel. So there are some challenges, with imaging, evaluation of response after treatment. Currently, CT and MRI is a standard treatment for, standard for follow-up for like ablation using cryotherapy or radiofrequency ablation, which is heat therapy. And they define recurrence as there's an enlarging tumor or new enhancement nodularity or enhancement abnormality in the area treated. So they define that as recurrence, but that doesn't apply for radiation, because the thing is, you ablate the tumor or you cut out the tumor is gone and you don't see it. And if something lights up, it's obviously tumor. But for radiation, the issue is after the tumor is not removed by physical means. And after the treatment, although the tumor shrinks, sometimes there could still be like some contrast, some dye left behind. But that doesn't mean failure, because we have seen over the years, many of those patients just got shrinking tumors or stable tumors of enhancement for many, many years without any progression at all, with no metastasis. So this is an example. In the lower panel, you can see that the kidney tumor before treatment, and after treatment, which is the upper panel, you can see that the kidney tumor is small. I'm sorry, and I can use the cursor to point to you, but just try to be more descriptive. So in the upper panel, you see that the tumor itself is much smaller, but it still shows some enhancement. That means the dye still persists on the scan. And also, sometimes, when we follow those patients, sometimes the tumor seems to be slightly more prominent, and it becomes smaller and then remains stable. So sometimes, if you have 1 to 2 individual scans that show that the tumor is slightly larger, I won't be too alarmed by that immediately. We need to look at it, like over time, because most of those patients actually, they have stable tumors in long term. So this is a diagram actually showing the tumor size change, based on the clinical trial we did when I was at the Case Western. And you can see that actually some patients, at some point have some increase in the size and then, decrease. And some of them had some increase in the size and then remained stable without any recurrence, after many years. So in summary, the advantages and disadvantages of radiation for primary kidney cancer. Advantages is it can be done as an outpatient treatment, safe and minimally toxic, provides some promising local control, no definite size limitation, no limit by tumor location, might stimulate some anti-tumor immunity, suitable for patients for surgically unresectable tumors or patients who are not suitable for surgery, and is possible in patients with a single kidney. But it does not enhance tissue sampling for confirmation of the type of the tumor after in terms of the response after treatment. And there's limited prospective evidence compared to surgery and the like radiofrequency ablation or cryotherapy. The safe low limit for kidney function before treatment remains undefined. And the optimal dose and fractionation, how we do it, is also undefined. And ID treatment response assessment, right now we're still trying to establish that. And actually, back a year or so ago, I was sitting in a panel for like the American College of Radiology, try to for the appropriateness criteria. I think Dr. Gore was also on that in that panel, and I was trying to bring up the issues of response evaluation after treatment, but actually the chair of the panel just scratched that and said, we don't have much evidence, so I'm not going to discuss about that. And very stringent technical and quality assurance requirements are extremely important, and there's a requirement for intensive training of the whole radiation therapy team. So yeah, that wraps up my presentation. And currently the IROC, the International Radiosurgery Oncology Consortium for Kidney, is actually doing a prospective registry collecting patient data from all around the world. And so hopefully, with this prospective registry project, one would be able to better define, the role of radiation in primary kidney cancer. Thank you.
Thank you, Simon. That was terrific. One question, although you touched on it on your last slide, but a participant said, would a person that has a renal tumor in a single kidney, they've had prior nephrectomy, how would that influence your enthusiasm for using SBRT to treat that lesion? Yeah,
so actually, yeah, I have an approach to that, and actually also thanks to Dr. Gore, he did mention, long time ago that typically, for nephrectomy patients, we want to make sure that there's at least an estimated kidney function of 15, which is the unit for evaluating the GFR. So what I do is I would actually look at the patient's estimated kidney function before the treatment, if there's a single kidney. And then I will actually, if I decide to do radiation, I'll run a plan and I'll look at, how much of the kidney it excluded from the threshold that I would damage the kidney tissue. And I estimate, I need at least 15 to make sure that the patient won't go into dialysis. So I use that as a benchmark to decide on whether I would offer radiation or not. So, there's a way to do it.
Yeah. Well, one last question. Another participant wants to know, does the histology matter? Is there differences for the approach with radiation therapy for clear cell versus the non-clear cell type of tumors?
Yeah. So actually, there's no difference in terms of the dosing. However, there are some type of kidney tumors that are not really cancer, like oncocytic tumors. If it's not like cancerous, we're not going to treat that. But for any cancerous tumors, any carcinomas, or some oncocytic tumors that are likely to be cancer, we treat with a similar dose. And actually, in the international database, the rate of recurrence is so low, there's actually no way to determine the difference, because it's over 95. It's around 95%. The local control in 5 years is long-term controls across the board, not just in a particular institution. Like in Australia, Peter Mac, like in Canada, you have Toronto, London, Western University, like in Japan, in the US, and across the board in Germany. And there's in Munich, there's actually no difference. It's across the board, we see the same results. So we do not distinguish between the histologies as long as it is cancer.
Yeah. Let me just ask you one last question, then we'll have to move forward for time, Simon. But your data on the success of treating a small renal mass is extremely good. In broad strokes, how does that compare to managing metastatic lesions with SBRT? Is there a higher failure rate you expect in treating a metastatic lesion than the primary?
Well, I think in my experience for kidney cancer, thanks to the immunotherapy, typically I see very, very few recurrences if the dose is high enough. So recently, actually, we just completed the international guidelines for SBRT for renal cell carcinoma. Is with the International Stereotactic Radiosurgery Society. It hasn't been submitted or published yet. We're about to submit that. But actually, when we look at the data, so there's like a cutoff. If we look at like free fractions, if we give 42 grain free fraction, we expect an over 90 to 95% of local control. So, and if we give that level of high dose to the metastatic lesion, again, I haven't seen failures. The failures I see are patients who got stereotactic body radiation therapy to like spinal tumors, because for spine, there's some limitation as to how much you can give because of a spinal cord. So usually for spine, the local control is not as good as in lung, liver. In liver and lung, you can, give a similar level of high dose of radiation. So I haven't actually personally seen too much recurrences in like liver and lung or even adrenal, from metastatic renal cells. So it boils down to the dose, I would say.
Yeah.
I don't think there's a difference. It boils down to how much you can give.
Excellent. Well, thank you, Simon. Appreciate it so much. So thank you to all of our speakers today. Those that are still with us, most had to sign off. So we're near the end of our program, but before we go, we did have one last speaker I'd like to introduce. Some of the topics today touched on advocacy for kidney cancer and fundraising for research. And if granting are the bricks that build a research program, then philanthropy is the mortar that fills in the gaps and makes it all work and makes it all go forward. And so I think relevant to today's overall goals is introducing and welcoming Nick Payton, Director of Philanthropic Gifts here on our campus, to just give us a couple of minutes about the role and activities of the philanthropy group, and perhaps commenting as well on the campus reorganization, the Fred Hutchinson Cancer Center, and how that's going to impact the work of the philanthropy team going forward. Thanks, Nick.
Thank you, Dr. Tykody. I'm just going to share my screen here real quick. Nick Payton, I'm a director of philanthropic gifts here. I'm filling in for my colleague, Megan Little, who is out of town today. We are both directors here. And in our role, we work with individuals who want to make an impact for those with cancer by raising money to help cure, treat, and better patient outcomes. We work with faculty like Dr. Tykody, Dr. Gore, to raise money for their research programs and to really accelerate science. And as you or a loved one may move through your cancer journey, you might ask or have a friend ask how that they can help. And philanthropy is a great way to fight back against cancer. Those donations often do so. Those who make donations often do so to thank their doctor for the care they've received or ensure a future where others may not be affected by cancer. So if this is an interest and you want to learn more about how you can help through philanthropy, please feel free to reach out. Our contact information is here on these slides. Additionally, the Fred Hutch is hosting our largest fundraiser of the year called Obliteride. It is Saturday, August 12th, and you can still register to participate. Options include a run or a walk, which I will be doing. You can also bike ride 25, 50, or 100 miles. Or if running or biking is not your thing, you can get your creative juices flowing by doing a virtual activity. And new this year, you can direct your dollars raised to specific faculty like Dr. Tykody or Dr. Gore. To answer your question about kind of the merger and with SCCA, really it's a effort to refine and focus better our collective efforts. And so it's really formalizing an informal partnership that we had in the past to really dedicate our resources to end cancer and all infectious diseases. So it's really exciting to partner as a complete group together with the SCCA, with folks at the UW Medicine, and with our own Fred Hutch scientists. So we really see opportunities for more increased collaboration, shared resources on technology, and more brain power to just really end cancer and all diseases. So hopefully that answers your prompt there, Scott, and thank you all for your time today.
Very good. Thank you, Nick. Yeah, and just to reiterate, in years past, there was separate philanthropic folks working through UW and SCCA and Fred Hutch, and now it's all streamlined. There's a single point of contact for the Fred Hutchinson Cancer Center. So it actually makes it simpler, one focus, one team, and could help people navigate and in whatever fashion somebody is interested to support anywhere across UW Medicine and Fred Hutch spectrum. It's just a single point of contact. So I personally feel like that's easier to sort out if somebody were interested to get involved. Excellent. Well, again, I want to personally thank all the speakers for today's program, all of our participants. And as I said at the outset, I encourage folks still online to consider giving us feedback. We do sit down and look through that, and it will help guide our thoughts about going forward. We expect to roll forward on an annual basis and be back next year and try to react to comments about how to do it different in years to come. So I'm going to step away and hand it over to Dr. Gore to bring us to a close. Thanks so much.
Thank you, Dr. Tykody. I do want to thank all of our speakers. This was a really wonderful lineup. I always love events like this where I know I learn a lot. Thank you to everyone taking their time out on a beautiful Saturday. Thank you to our attendees as well. I really appreciate all the engagement in the chat, and we look forward to seeing you guys next summer.
Hold on, next slide, please. One more slide, Dr. Gore.
Sorry about that. We do want to thank Ritu. This is a very challenging event to prepare. It's a very challenging event to coordinate. We have a ton of speakers. There was a lot of background work that went into it. And so I want to give a very special thanks to Ritu for all her help and support in making this happen. So thank you so much. Thank you, everyone.